This meeting is being recorded.
Hello, welcome to the Ohio Department of Mental Health and Addiction Services Crisis Academy on the EmPATH model in behavioral health urgent care. My name is Molly Drolashek and I'm the program coordinator at the Ohio Association of County Behavioral Health Authorities. We are so glad you could join us today. A few housekeeping items. We are using Zoom webinar today, so you will not be able to use your microphone or video, which means we cannot hear you or see you. The chat function is also disabled today. However, we will be able to send you information through the chat. If you have any questions during the presentations, feel free to add those to the Q&A box. We have reserved time for Q&A at the end of each panel presentation. Please keep your questions related to the content and topics we are learning about today. If you have any technical difficulties throughout the training, please contact me. I will be posting my email in the chat box for your convenience. For continuing education credits, this training has been approved for 4 hours of CEs for the following disciplines: nurses, social workers, counselors, prevention and chemical dependency professionals. By logging in today, your attendance is tracked. We will not be awarding partial credit. We encourage you to stay the entire time in order to receive credit. Please note that we are also unable to verify attendance for those who joined the webinar by phone. At the end of the webinar, you will receive a link to a 2-part evaluation. Please complete both evaluations within 1 week of the webinar in order to receive your CEU certificate. Certificates will be emailed to you approximately 2 weeks after the webinar. This webinar is being recorded and we posted it on the Ohio Department of Mental Health and Addiction Services website. I will now hand it over to Director Lori Chris, Director of the Ohio Mental Health and Addiction Services.
Good morning, everyone. Thank you so much for being here and welcome to Ohio's State Fiscal Year 23 Crisis Academy series. Today, we're highlighting the EmPATH model and behavioral health urgent care. The webinar today is going to focus on both the Emergency Psychiatric Assessment, Treatment, and Healing, or EmPATH model, and behavioral health urgent care models, and how they're being used within the crisis continuum of care. Some of these models are being used in Ohio. Behavioral health urgent cares are growing here in the state, and the EmPATH model is really started on the West Coast and is moving across the country, and so we're interested in it here in Ohio too. Dr. Scott Zeller, the developer of the EmPATH model, is going to be sharing how hospital systems have used this model to improve client care while avoiding unnecessary times in traditional emergency departments waiting for psychiatric services. And Travis Atkinson from TBD Solutions is going to provide an overview of behavioral health urgent care models. We also have with us today 2 local systems of care who will share their experiences in starting a behavioral health psychiatric urgent care unit and the challenges and opportunities that they're seeing with this innovation and what they've encountered and how it's improved crisis care in their communities as well. And so I want to thank Licking County, Licking Knox and Lucas, Kay Spergel from Licking Knox, Catherine St. James, Kate from Behavioral Health Partners there in Newark. And I've been able to visit their site. And then also Scott Silak from Lucas County and Courtney Burrow with Zeph Center. And I've been able to, witness and see firsthand the crisis continuum that they're lifting up there as well. So we're excited to have that local learning and experience available. We have continued this learning collaborative for 4 years, so I'm really grateful for everyone's participation and proud of what we've lifted up together. This is our 12th Crisis Academy, and we continue to learn more and more about new and innovative environments that other states are using and work that's happening here in Ohio to support crisis continuums. And we are continuing to, we'll continue to gather in this way in the next biennium. So looking forward to the next 4 years, continuing to grow our crisis continuum to learn from one another and to learn about innovations in other states as well. These are intended to really start thought-provoking conversations and spur new ideas on what's possible at the local level. These academies, in combination with the crisis assessment and planning processes, the community assessment and planning processes, are designed to really help lift up the opportunity for every Ohioan to get crisis care close to where they are every time they need it. And I'm grateful for all the work that all of you are doing to lift that up. So welcome again, and I'm going to turn this back to Akba for the launch of the program.
Thank you, Director Chris. Next, we will have Susan B. Miller speaking, who will be sharing her experiences with Ohio's crisis systems.
Hello, I was asked to share my story. I have a 17-year-old child who has been suffering from mental illness since the age of 12, really, since puberty started. And I actually last night I have not slept because I was in the hospital with him last night. He has serotonin syndrome, which I don't know if you're aware of, but it's from the psychiatric medication. And so I luckily wrote everything down. So I did that in order to not forget anything important. And I'm going to share my screen with you. Oh. Am I still there?
Susan, yes, you're still there.
I see nothing.
You know what? If you're not able to share your screen, just continue to share your screen.
Can you see this?
No, it's not coming across, Susan.
Okay. I am not seeing how about if I just read it?
Yeah, that's
I'll be able
perfect.
to see it. Okay, because I can't figure out how to share it with you. Okay. Okay, it's the beginning. When Katie was about 1 year old, she and her mom, my daughter, came to live with me as a result of domestic violence. My daughter lived with us until completing her nursing degree and then moved out and was in and out of Katie's life. Katie and I were kindred spirits. We loved riding horses, going to the ocean, and baking cookies together. I legally adopted her when she was 9 years old. I was thrilled to go from a last name beginning with a W to a B, moving her from the back of the line to the front alphabetically. The judge said to us, now this is for keeps. There are no backsies. From here on out, you two are in this together for the good, the bad, and the ugly. When puberty hit, it got pretty ugly. Depression followed by self-harm, hospitalizations, more than 10 stays in crisis units, including Ohio Health, Nationwide Children's, Akron Children's, and OSU. 2 residential stays and countless emergency room visits. During this time, Katie, who had always been a very girly girl, sat me down and said, "Nana, I'm transgender. I feel like I am a male. So from here on, I will use he, him pronouns and the name Kay." Into the system. Kate made some false accusations to the counselor at school, and of course they had to call Children's Services. When the counselor told Cade that a caseworker would be at our house that evening to check on things, Cade must have panicked because he wasn't at the school when I went to pick him up. The school nurse explained what had happened earlier that day, and we determined that he must have run away. I went home and called the police. Meanwhile, CPS called and stayed on the phone with me, offering guidance and support until Cade was found. The accusations were deemed unsubstantiated, but I asked to leave the case open voluntarily. CPS, it's been like 3 years now, CPS has been a tremendous resource, getting us connected with Richland County Youth and Family Council and PASS funding, which have both helped with the costs of service dog training, monthly respite weekends at Camp New Hop, IHBT, and residential room and board. And I'm going to share a few things that are near and dear to my heart as far as things we really need to work on, or things that have gotten better. Sensitivity training is critical for health workers, paramedics, and police officers. An ED doctor told me that Cade was faking seizures and that I should tell him to stop, or it was going to be embarrassing for him at school. But he doesn't believe in all of this politically correct nonsense and calls it as he sees it. I had already been to the PNES clinic at Nationwide, and I explained what pseudo seizures actually are to him and that they are not consciously produced. I then wrote a letter to the hospital administration explaining my encounter and suggesting they educate their physicians in regards to the newest research in this area. They responded promptly and promised to address the situation. We experienced police officers who obviously did not have CIT training in de-escalating a triggered mentally ill patient, but instead exacerbated the situation by yelling at Cade to calm down and stop screaming. I had to intervene and explain that his tactics were not working. With the help of a more understanding officer, we were able to get Cade to the hospital via squad. When I called the police chief, he wanted to know if I wanted to file an official report. I said, no, I want you to fix this so it doesn't happen to someone else. Update, the police that came to take Cade to the hospital 2 weeks ago were amazing. They stayed firm, but were patient and kind as they waited with Cade, holding him to prevent him from hurting himself until the ambulance arrived. I thank them for their kindness and for keeping my child safe. Anyone who works with people experiencing mental illness or with their loved ones needs sensitivity training. This includes law enforcement, paramedics, doctors, nurses, office staff, teachers, really everyone, or anyone who's going to interact with someone who's suffering from mental illness, so they know how to respond in the most helpful, respectful way to someone who is already struggling. And this one's the most dear to my heart, continuity of care. There needs to be communication between a patient's private psychiatrist and counselor, and the psychiatrist in the crisis unit or residential facility. They should talk routinely regarding active patients. I begged the counselor at the residential to call Cade's private counselor, who had been working with him for 2 years. She did not, but finally came to the same diagnosis when Cade was due to leave residential. So much time and opportunity for treatment was wasted. Cade's private counselor and psychiatrist attempted to connect, but ended up playing phone tag. Educated minds collaborating regarding what they are seeing could be game-changing. It should be required. And accessibility. Patients must be able to communicate directly with the provider, be it text, email, or phone call. Cade was supposed to have a follow-up appointment with a psychiatrist following residential. They gave me an appointment, but it was 2 months out and said it was the best they could do. Then they called and moved it out a month further. Meanwhile, my child ingested 7,000 milligrams of Topamax. When our psychiatrist came into the hospital room, I told her how disappointed I was in her. She looked surprised and asked why. I explained through tears what had transpired. She apologized and said that never should have happened. She told me to ask the staff to allow me to speak to her directly. I told her that I have no faith that would work. So she gave me her personal number and told me to text her when I need help. That was obviously a case of disconnect between the doctor and staff, which could have resulted in a fatal consequence. IHBT, intensive home-based therapy. We are currently participating in IHBT. In Mansfield, Family Life Counseling is the only organization that provides this service, And at the present time, there is one counselor for all of Richland County. There is another counselor from a neighboring county who sometimes fills in. The last time we needed intensive home therapy, we were placed on a waiting list. People needing this service cannot wait. Private insurance does not cover IHBT, and it is cost prohibitive unless you're on Medicaid or can find funding elsewhere. Fortunately, our caseworker from Youth and Family Council was able to secure MSY funding to cover this expense. And lastly, the resources for young adults. CADE's care team, caseworkers, therapists, and psychiatrists doubts CADE will be able to live independently in the near future. CADE wants to be independent, dreams of going off to college, but with cycles of hospitalizations every 2 months, it is not likely. I fear that he would be dead within a month of going off to college. He needs a type of group home for young adults that has 24-hour supervision with safety precautions. He could take college courses online and work in a supervised setting while getting therapy and working toward a goal of increased independence. I have not yet found anything like this for his age group. My greatest fear is that if anything happens to me, he will have nowhere to go. I love this child more than words can express. My hope is for Cade to have a good life and to be a contributing member of society, to love and be loved. And that's it.
Thank you so much, Susan, for sharing your story. We really appreciate you being here and sharing your experience with us. We like to invite those with experiences in our crisis academies to set the foundation for what we're learning about today. So thank you again.
Yeah, and before we move on, Susan, thank you for being so just rawly honest and sharing where it's not going well and where you've seen improvements too. And please, continue to let us know what you and Cade need so that that vision that you have and that hope that he has can be a reality. Thank you so much.
Thank you for letting me give my story. And I hope that it helps in some way.
It helps in great ways. So thank you very much.
Okay. Thank you. Bye.
Thank you again, Susan. So now we will have Dr. Scott Zeller present. Dr. Scott Zeller is the Vice President for Acute Psychiatry at the Multi-State Multi-Specialty Physician Group Partnership by TBD and founder of the EmPATH model. Q&A will occur at the end of each presentation. Please feel free to ask questions during the presentations in the Q&A box. Elijah Jones will assist with asking questions at the end of each presentation. So Dr. Zeller, I'm going to share my screen to share your slides here. Okay.
Oh, fantastic. Looks like it's working. Am my volume coming across okay? I'm actually in a hotel room in Phoenix. I'm at the National Update on Behavioral Emergencies Conference, which is the biggest annual event for people who work in crisis and emergency psychiatry. And I was glad I was able to connect with you all from my hotel room before I go for a day of learning some neat things. And I'm just, is everything coming across okay? Just want to make sure because I'm not used to speaking out of a hotel room.
We hear you.
It's all loud and clear?
Yeah,
Okay.
perfect.
So great to hear. And actually, what's been really neat, I was telling you that, I'm at the National Update Behavioral Emergency Conference, which is colloquially called the Newbie Conference. There's been a lot of discussion during this conference for the last few days about the EmPATH model and different places from around the country talking about the wonderful results and the wonderful outcomes that they've been able to achieve since they've adopted EmPATH in their places from Florida to Minnesota to Arizona to Washington State and remote as Montana and Wyoming. It's just really gratifying, and it's fabulous to hear all the things that people are doing and really filling this unmet need that we've had in far too long in crisis and emergency behavioral health care. And I really want to thank the person who preceded me with a very heartfelt story. And one of the things that we hope with EmPATH is that people will never have to go through that difficult situation again and really get their needs met much more promptly in a more appropriate and therapeutic location. And that's kind of what drove the creation of the EmPATH model. And who could hear the story that we just did and not really feel very strongly that how could we need to do better. And hopefully EmPATH is one of the ways that we can start doing better. So next slide. So here's one of the things that drove the creation of the EmPATH concept, and that is that there has been an enormous growth in the need for emergency and crisis intervention, stabilization, behavioral options over the last decade or so. And we've only seen this really exacerbated from the pandemic. But even before the pandemic, these numbers actually come from the period between 2006 and 2016, that we saw an enormous growth in the number of people with psychiatric emergencies coming to hospital emergency departments. And I think the most amazing thing, you see some really stunning statistics on this slide, where we're seeing the growth from people coming to ERs going up 50%, 56%, 40%. Their length of stay in the ERs going up by hours. But maybe the one on the far right might be the most really stunning statistic, and that was just in that period between 2006 and 2016, the number of people coming to hospital emergency departments in the USA for reasons around what we would call suicidality, which is suicidal thinking, suicide attempts, anybody who's after kind of anything that would have happened with an overdose or attempt to asphyxiate themselves or anything like that. The number of those folks coming to hospital emergency departments went up over 400%. And that's a staggering number when you really think about it. And unfortunately, what we've been seeing on top of already that huge rise from 6 years ago, the numbers have only gone up much more precipitously since we've had the pandemic. Next slide, please. And it's gone up so much that now the number of patients coming to hospital ERs across the USA has gotten so much that basically 1 in every 7 patients that's coming into ERs around the country are there for a behavioral health emergency. And that's amazing when you think of what ERs are set up for and all the wide swath of different patients they see. Behavioral emergencies are now similar numbers for people coming in with things like chest pain, with infections, with cuts or bruises or broken bones and all those kind of things. Think of all the things that you could imagine that people would come to hospital ERs now. And it's amazing that one of the most prevalent things is behavioral health emergencies. And we're looking at that probably 8 to 10 emergency psychiatric evaluations are going on in the United States at this point every year. And that's an amazing number. So that means that, 1 out of every 20 people in the USA is coming into a hospital ER for a behavioral health reason every year. And it just keeps growing because there's so many people who unfortunately aren't seeking help and ones that for one reason or another really aren't able to access help. So this is a stunning indicator, and it shows that we have a lot of room for improvement. Next slide, please. So an important thing to understand is that according to federal law, psychiatric emergencies are medical emergencies. And that's an important thing to know. And it's actually a good thing. It means that these are priority cases that hospitals need to take them just as seriously as people coming in with car accidents or heart attacks, anything like that. So some of you may not be familiar with the federal EMTALA laws, but you probably have all heard that there's a federal law that means if you come to a hospital ER anywhere in the USA, by law, they can't ask you if you're able to pay. They can't ask you if you have insurance before they take a good look at you and determine whether or not you have an emergency condition, and they are required to try to stabilize that emergency condition, again, without inquiring as to ability to pay. So it's a good law, and it means that if you're able to get to a hospital, no matter what your situation is, they are going to do what they can to help you and treat you. And that we need to all be appreciative that hospitals are not only required, but I've never met a hospital that is not willing to meet that requirement. But historically, there was some confusion, let's say, over mental health emergencies, where they were saying, gee, you know, we're set up here for heart attacks and car accidents. These are now medical emergencies as well. And yes, because these are priorities. These are people who are suffering. Sometimes it's a life-threatening situation, just like car accidents and heart attacks. And so hospitals not only need to be prepared for this and understand this is one of their most common presentations that they're going to see, but also really be ready for it in terms of having staff that are trained in knowing how to work with behavioral emergencies, having that kind of toolkit with training for all their staff on what the differences are for intervening in behavioral emergencies. And it's not like putting somebody with an IV and sending them off to get a CAT scan, that there's a different way that you would treat behavioral emergencies. And so it's really long past time that all hospitals need to be understanding and prepared for these situations. And the good news is many of them are, and the most of the rest of them are really eager to learn. So next slide, please. So with all the people coming to hospital ERs for behavioral emergencies, is a thing that has been going up over the last 10, 20 years. And you may have even seen a news story in the New York Times, the Washington Post, or on 60 Minutes, or on the internet, or all kinds of things, which have been talking about how many people have been coming to hospital emergency departments with behavioral emergencies, and how it's sometimes, unfortunately, a mismatch because the hospital emergency departments have been historically set up to do an evaluation of somebody's condition, make sure they're medically okay, and then they try to find them an inpatient psychiatric bed. And that's kind of the algorithm that they've been following. I'm sorry. So when people were hearing about this and the dramatic rise in patients coming to the ERs, the initial thought, and a really good one, is how can we offer an alternative to people? How can we find a different place for them to go so they don't have to go to the ER? And a wonderful concept, and has led to the development of some amazing and really fabulous programs. Best of all, maybe, is mobile crisis, where people who are in crisis or suicidal or having acute symptoms of severe mental illness can actually have somebody come to their residence where they're living, or even where they are on the streets or whatever, and try to help and intervene with trained professionals. Wonderful program. There's also been development, and we're going to hear some more later. And I understand that Travis Atkinson is on, and an amazing person, and I'm honored to be on the same docket with him today. And I'm really looking forward to hearing his presentation, because he's done some wonderful and innovative things, and we're going to hear about that. So all these wonderful programs will be created, being mobile crisis, psychiatric urgent care, drop-in crisis centers, counseling centers, all these fabulous things. I think there's the only one problem with it has been there might have been a misperception that if we only create a certain number of programs, nobody's going to have to go to the hospital ER again with the psychiatric emergency. And sometimes, unfortunately, maybe there was even a pitch that suggested that would be the case. But as we've seen the development of these wonderful programs around the country, the unfortunate thing is that the number of patients coming to hospital ERs has not decreased during that time. In fact, even in places with robust crisis systems, they're still seeing the same numbers. In many cases, even seeing more patients than they did before. And so one of the nice differences, as I mentioned a moment ago, is that I think hospitals have really gotten beyond the point of thinking, oh, if we could just get one more program, people won't be coming to the ER anymore, and starting to realize, you know what, the federal law says these are medical emergencies. We know they're medical emergencies. We need to treat behavioral health emergencies with the same seriousness that we do with physical health emergencies. A heart attack or a car accident is the same thing as somebody who's acutely suicidal, and we need to treat it with the same kind of urgent intervention, care, and empathy that we would with any other emergency that we see. Next slide, please. So perhaps you might say, gee, there's all these great programs. How is it that people keep coming to the emergency department? And this is from an article that I published in a journal 3 years ago about what the reasons are that sometimes people, no matter if you've got the best community crisis programs system spectrum in the world, there's still people who are going to come to the ER with behavioral emergencies. And why is that? Well, for one, most of the community crisis programs are really set up for high functioning, mild to moderate severity patients. And that's a good thing. We want people who are able to recognize that they've got something going on, they want help, they're able to reach out for help voluntarily, that they have access to quality programs, and that's great. But unfortunately, in terms of thinking that that might be the cure-all for everything, most of the people who are coming to hospital ERs are actually not mild to moderate, but actually moderate to severe situations. They're often on involuntary psychiatric holds that are placed by police or other people who are authorized to do that. And if you even have a situation where you might be too highly acute for some of these wonderful community programs, they recognize that that's beyond their capability, and they have algorithms which say if somebody comes in with X, Y, or Z, we either tell the police or ambulance that may have come to our door, you need to really take this person to the hospital ER, or they may even have a situation where they have to call 911, and then 911's response will take them to the hospital ER. So what's some of the examples of that? People who are really acutely agitated, aggressive, violent, or they're known to have been really violent in crisis intervention in the past, those usually kind of end up going to the hospitals. People who are profoundly having symptoms of psychosis, actively hallucinating, incredibly paranoid so that they're responding to anything with aggression in response, or if they're really confused and disorganized, and it even raises the issue, if they're that confused and disorganized, is this indeed a behavioral health thing, or maybe are we concerned there might be something like a stroke that's going on, or something other significant along those lines? We can be concerned about somebody who is so suicidal that at that time they are unable to be by themselves for any length of time, because if they are alone, they might try to do something to hurt or injure themselves, and so they need a serious level of supervision. We often see that the community programs can't actively work with somebody who is severely intoxicated, or if they're in any kind of drug or alcohol withdrawal that is life-threatening. And as you probably all know, opiate withdrawal can be life-threatening, alcohol withdrawal can be life-threatening, and those need to be in a higher level of care, a medical level of care. Anybody who's on an involuntary hold, many community programs can't work with involuntarily detained folks. They can't work with anybody who's on their way to jail, who needs an evaluation and has criminal charges. But perhaps the most common one that people end up going to the hospital for is serious comorbid medical issues. And probably the most obvious is if somebody's taken a big overdose attempting to kill themselves, you can't really take them to the counseling center. They need to go for immediate medical intervention to save their lives. So again, no matter how great your community crisis program is, they're not going to be treating people with overdoses. They're not going to be treating people who has cut on themselves and are actively bleeding. And so those folks are going to go to the ER as well, as would anybody with any other serious medical comorbidities. If their vital signs are out of control, or if they're refusing meds or refusing treatment, they're going to end up in ERs. Next slide, please. So one nice thing about ERs, which is different than everywhere else in many ways, is that ERs accept everybody. And in fact, that federal law, EMTALA, the Emergency Medical Transfer and Active Labor Act, says that it's against the law for the ER to turn away anybody. And that's a good law for that reason. But I can tell you from working with ERs and emergency medical personnel for many years, nobody would ever want to turn anybody away anyway. They don't need the law to have them do that. They really want to help folks. Some are better than others. Some have some personnel that might be a little brusque, hearing the story earlier, and I've certainly heard some other unfortunate stories. Sometimes it's not the best way of doing things, but overall, I think in general, the vast majority of people who work in emergency departments are good people who really want to help, and they recognize that psychiatric emergencies are medical emergencies, and they want to be able to be there and help folks without regard to any kind of issues of racial, ethnic, LGBTQ, any other population. Anybody who's coming in, they're going to get help, they're going to get evaluation, and they're going to do what they can to help get people through this crisis. So sometimes we hear about a no wrong door concept, and that's a really good idea, which means if you need help and you go to the ER, that's great. If you go to the community urgent care, if you go to the psychiatric counseling center, if you go anywhere, there's no wrong place when you're in crisis. And what we need to do is make sure that whatever door you take, we're prepared to help you out and get you through what might be the worst day of your life. Next slide. So one thing that has happened, though, with this big rise in folks coming to hospital ERs for behavioral emergencies is that it's led to some bottlenecks and inefficiencies, because the hospitals weren't really designed in the first place with the idea that they'd be seeing people with behavioral emergencies, at least not that many. So what we've seen over the last few years is that the average person coming to a hospital emergency department with a behavioral emergency is staying there usually more than 3 times longer than people who are there for any other condition. And it's not a good thing for the ER, because that prevents them from being able to keep those beds being turned over, if you will. The way ERs work is that there's hundreds of people who come in every day to see them and wanting their help. And the only way they can see everybody is if they're continuing to have somebody come in, do everything that they can to help them out, make sure they're in good shape, get them out, then the next person comes in. So you keep that kind of shoveling the walk while it's still snowing concept going for your entire shift, for the entire day. And that's what you do in an emergency department. You're helping everybody as they come in, and hopefully you're able to do it in a relatively short amount of time, because there's a lot of people waiting. And unfortunately, behavioral emergencies tend to take a lot more time and take up space. And that means a lot of people are sitting in the waiting room, waiting for a lot longer than they would have otherwise when these beds are being taken up. And again, it's not so much the fault of anybody who's got those conditions. It's not the fault of the ER. They just really weren't set up for it historically. And so it's led to some kind of mathematical, non-matching, if you will, and people be getting stuck there when maybe if we did things a different way, there would be a better outcome. It also costs hospital a lot of money. Here's a number from 2008, this study, where it said every time somebody with a behavioral health emergency gets stuck in an ER waiting for long hours so that they can get transferred to a psychiatric facility, it's costing that hospital over $2,200. And like I said, that's about a 15-year-old number. I bet that's double that by now. Next slide. So the phenomenon that costs those hospitals so much money and is really, really unfortunate for everybody along the line is something called boarding. It's not good for the patients. It's not good for the ER. It's not good for the hospitals. It's not good for the system. And basically, boarding is somebody comes into the hospital ER. The hospital ER's concept is, if there's a behavioral emergency, we do a really good medical screening examination. We determine that somebody has no other acute medical condition than their psychiatric emergency, and then we're going to refer them to an elusive inpatient hospital bed, and we're going to fax charts around to a bunch of different places within 100, 200 miles of us, and hope that somebody has the ability to take this individual and we can transfer them to them. So that might have worked when the number of patients coming to ERs 20 years ago was maybe 1 in every 20. Now that it's 1 in every 7, the math doesn't work. There's actually fewer inpatient beds now than there were 20 years ago. And there's, as you've seen from the data that we shared earlier, there's far more patients needing emergency intervention. So what that leads to, with everybody waiting for this transfer, it can take hours. It sometimes can take days. And so the phenomenon is called boarding, where you have somebody who's stuck waiting in an emergency department for long hours, sometimes days, for transfer to a psychiatric facility. Other than the psychiatric emergency, they're medically okay, but they're left kind of sometimes stacked in hallways, untreated, nothing going on, no intervention, no support, not even as much as a magazine or a book to look at, or television or anything, just kind of, as you can see in this picture, just kind of stacked in the hallway, waiting. And your rare intervention with people might be every few hours, somebody comes by, takes your vital signs, and brings you a lunch tray or something like that. And that's all you've got going on. It's untreated. And imagine, it was already the worst day of your life, and now you're not getting help. You're lying there untreated, waiting for a hospital bed. You don't know when or if it's even going to be coming for you. And would that make your symptoms worse? If you're already having the worst day of your life and you're put into that, doesn't that sound awful? Doesn't it sound horrible? And if you were despondent or hallucinating or had anything else going on, you're like, wow. And so it's well known and it's well established in the literature that this situation boarding is not only not a good thing for anybody, but it often can make psychiatric emergency conditions much, much worse. Next slide. So we had all these numbers and we have this boarding problem. So then on top of that, as probably most of you who are on this call know, in July, 988 debuted nationwide. And just for those of you who may not be aware of it, 988 is a new nationwide 3-digit phone number, just like 911 that you would call if there was a fire or a police need. You can now call 988 if you have acute suicidality, you've got a psychiatric emergency condition, and they can connect you to people who can do over the phone counseling. And if you need something more, they can connect you into the system so that we can get more acute on-site interventions, or somebody can come to your site and help you out, just like they would with 911. Wonderful, wonderful thing. People have been working towards it for years. This replaced a little bit more difficult way to access, which was the 1-800-273-TALK number, the National Suicide Prevention Lifeline. Wonderful, wonderful folks. The Dr. John Draper, who's run that program for years, is one of the most amazing people you ever meet. And you would wish that everybody you knew was like him, because such a good and selfless person who's dedicated his life to making sure people in crisis have access. And one of the great things that has emerged from all this is that now, instead of somebody who's suicidal or despondent or having terrible psychiatric crisis having to dig through drawers or find the yellow pages or something like that to say, like, what's that number? I want to talk to somebody, and have to find, oh yeah, 1-800-273-TALK. That's probably a bit difficult to remember, but 988, we already know 911. So 988, that should be a lot easier for folks to remember and utilize. And indeed, the good news is that since 988 was started in July of this year, it's been close to 6 months now, we've seen an amazing amount of utilization of it. So people are accessing the 988 system. It's good. We want people to be able to utilize this system whenever possible. If they need help, it's got to be quick and easy to access. And that's one of the beautiful things about 988. But before 988 came around, and things like Dr. Draper's Suicide Lifeline, just people calling 911 asking for help for a mental health crisis, the other kind of lifelines, hotlines that have been out there, it was estimated a couple of years ago that the number of people utilizing all the different behavioral health hotlines and access lines in the country was about 40 million calls per year. Since 988 has come on board, that number seems to have gone up over 50%. So now maybe we're looking at 60 million calls per year. So even if the hotline is able to do a wonderful job and stabilize 99% of those people that they're in touch with over the phone and get a great outcome, when we're talking 60 million, even 1% is 600,000 people who need more intervention and need more help. And that's going to involve police, fire, ambulance, hospital ERs, all these kind of different levels of care. Even if we do a fantastic job, there's still people who are going to need a little bit more and a little bit outside the system. Next slide. So going back to the whole thing about hospitals looking at boarding and the issues with the boarding situation. And so the average person, and this is actually why I started doing work in this area and started doing research in it, because I found the news stories, whether they're in New York Times or 60 Minutes, Washington Post, CNN, they would do these feature stories about people with psychiatric behavioral health crises stuck in the ER for days, waiting for a transfer. And everybody agreed, this is an awful thing. Who could disagree on that? But they would do these stories, and you would think that somebody never thought there was a possibility to do things any differently. So the general gist of the story would always be, these people came to the ER with a behavioral health emergency, and it was determined that they needed inpatient psychiatric hospitalization. And now they're waiting here for long hours, days, waiting for that inpatient bed to come open. And so in these same news stories, they would say like, well, how do we fix this? And people would say like, well, they're waiting for an inpatient bed and there's not enough inpatient beds. So let's build a lot of more inpatient beds that'll solve it. And I'm the last person to say we don't need more inpatient beds. Clearly we do. So that is something that should be done. However, the idea that solving this whole issue in the emergency department by just continuing our same algorithm, our same methods, and just moving, kicking the can down the line and saying, we're going to send everybody to the inpatient hospital. Well, it just doesn't make any sense. And it's not really thinking of the way that we do things for everyone else. For example, if you came into the hospital ER, and let's say you have an asthma disorder and you're having a real hard time with shortness of breath. And so you come in like, can't breathe, please help me. Asthma attack. And if we did intervention for those folks like we do with the psychiatric emergencies in most hospitals, the nurse would meet them and say like, oh, I'm so sorry that you're going through this inability to breathe. Let me walk you to the back of the ER. I'm going to sit you down there and we're going to like start calling around and see if we can find an asthma hospital to transfer you to. So try to keep your breathing okay, and we'll get you there. Just don't worry. It should be with just a day or two what we can get you the help that you need. I mean, that sounds ridiculous, right? We would never do that with somebody with an asthma attack. We'd get them right on a nebulizer or oxygen or whatever they needed so that they could start breathing. It's the same thing with behavioral health emergencies. We should be helping people at that time of need, at that front door, at that issue when they really need our help, and not just saying, we're only here to hold on to you until we can send you somewhere else. We would never do that for any other medical emergency, and we shouldn't do that for behavioral emergencies as well. And so the idea that we just need to build more inpatient beds not only continues that old-fashioned idea that we're only here to make sure you're otherwise medically okay and get you in the ambulance to transfer you to that psych hospital. It really ignores the idea that from all the research, all the data shows that the great majority of people with behavioral health emergencies can be stabilized in less than 24 hours if you follow some simple, really humanistic, patient-centric methods. And the idea that you're going to send people to inpatient as your default treatment is really unfortunate. I mean, it's the only condition seen in ERs where the default treatment is find them a bed, and it's the wrong decision. Yes, if people need to be hospitalized, absolutely. We need to make sure that they can get hospitalized. We need to make sure that we've got that level of care available, but we don't just pass through everybody in the emergency department as sending them into ER. It's a very unnecessary hospitalization in most cases, and it's a very restrictive and a very expensive level of care. The thing that we could compare it to is if somebody came into the ER and they're having bad chest pain, you think they might be having a heart attack. People come to the ER, chest pain is very common. If we thought that everybody who came into the ER with chest pain needed to be admitted to a hospital inpatient bed, right now, maybe we would be having a seminar on the shortage of inpatient medical beds in the country because we're admitting everybody with chest pain. It turns out only like 10 to 20% of chest pain patients need to be hospitalized. So what's amazing is that maybe only 10 to 20% of people with behavioral health emergencies need to go to inpatient psychiatric hospitals. It's a very similar number. And if we just change our thinking, change our dynamic, change our algorithm, we can actually make things work in a much better way that's more beneficial, win-win-win for all. Next slide. So as I mentioned, it's the wrong idea. Thinking of the only solution is building more inpatient beds is not going to fix what's wrong with the system. And yes, as I mentioned, more inpatient beds would be really welcome, and I'll be the last person to argue against them. However, we at the same time need to do a much better job at that emergency level of care in the hospital. And that begins with the understanding, the recognition that the great majority of psychiatric, behavioral health, substance abuse emergencies can actually be stabilized in less than 24 hours. We can take an emergency patient and change them into an outpatient, take away all those life-threatening and emergency conditions and get them in good enough shape so that they can go back home, and then we can work on it at a much more therapeutic, less restrictive level of care. So if we're going to really change this whole system and get rid of boarding and get rid of those bad outcomes and all those other unpleasantries, it's not that we need to build more inpatient beds, although, as I said, that would be a good thing on its own. However, if we're really going to fix the current system, we really need to change the approach at the emergency department level of care. Next slide. So that leads us to the EmPATH model. And perhaps many of you have heard of EmPATH, and EmPATH is an acronym. And I was just at a meeting yesterday at this big conference I'm at, and somebody said, well, EmPATH, that's a pretty snazzy term. Who owns that? That sounds like it's like Kleenex or Jello or something like that. It's somebody's copyright. It's a trademark. And no, actually, EmPATH is an academic term. It's a generic academic acronym. Any program that follows the basic concepts of the EmPATH model can call themselves an EmPATH unit. And you can be an EmPATH unit and you don't have to be called an EmPATH unit. You could call your unit Fred if you wanted to. It's important that you follow the EmPATH model, and that's all that's about it. Nobody owns EmPATH. Nobody's copyrighted, trademarked it. You don't have to pay a license to have an EmPATH unit. And indeed, many places are opening up EmPATH. And I think that's generally recognized at this point that EmPATH is the same way that we use other acronyms like CSU or ICU for intensive care unit, or all kinds of other things that we use in healthcare. EmPATH is an acronym like that. Next slide, please. In fact, if you needed any more support for what I just said, EmPATH units are now defined and have their own page in Wikipedia. And somebody once said to me, wow, if you're on Wikipedia, that means the world knows that you're there. And so in the olden days, you could probably put anything on Wikipedia. From what I heard from the person who put EmPATH units on, who's one of the leaders of Wikipedia, it's almost impossible to get anything on. The Wikipedia is now as strict as Webster's dictionary. So the fact that EmPATH units are now something that's recognized by Wikipedia, again, shows you this is not a brand name. Nobody owns it. It's not some kind of snazzy concept. It's a real part of emergency psychiatric care that's well explained in the literature. Next slide, please. So EmPATH units are based on what are known as Zeller 6 goals for emergency psychiatric care. And these goals you will find many places in the medical, behavioral health, psychologic, psychiatric literature. It's basically the approach to high-level evidence-based emergency behavioral health care. And the one thing that's kind of neat, you may remember from my kind introduction that my name is Zeller too, just like Zeller's 6 goals. And you know what's really cool about that? It's because I wrote them. That's my thing. So I won't go too much more into that. Only that the reason that they started becoming Zeller 6 goals, when I originally wrote these about 15 years ago and got them published as part of a big emergency psychiatry paper that I did, the intention was always these should be the 6 goals of emergency psychiatric care. And I'm not the kind of person who ever wanted to have my name on top of something like this, but I was giving a presentation at an international psychiatric conference in Madrid, Spain. And when I was doing that, there was a fellow in the audience who was sitting in the front row, and I was doing my different slides, including the 6 goals of emergency psychiatry slides. And this fellow, this Austria doctor, was taking photos of every one of the slides that I was presenting. And so I'm seeing him doing this, and I'm thinking like, whoa, I must be like really wonderful. And this guy wants to like remember everything that I said, and he's taking pictures of my slides. He must really find this impactful. So this is great. And then the next day at the same conference there in Spain, I went and sat at what sounded like an intriguing lecture. And there, sure enough, in the front of the room was this doctor from Austria, and he was doing an interesting presentation. And it was really interesting because he was presenting my slides. He had just taken photos of them, and there he was showing them on the wall, except he had attributed everything that we had done to himself. So we got there, and it was like Schwarzenegger's 6 goals of emergency psychiatry. And so when I saw all that, and some colleagues said, Scott, you need to make sure your name is better associated with us so that other doctors can't claim them. And so for better, for worse, they're now known as Zeller 6 goals. So anyway, here's what the 6 goals are, and they're kind of in the order of the way that you want to intervene with an emergency psychiatric condition. First off is that you want to exclude medical emergency etiologies for those symptoms. You want to ensure somebody's medically stable. Why is this a big deal? Because based on where you are, where you're reading your different studies in psychiatry and emergency psychiatry, anywhere from 10 to 25% of patients who have what appears to be an emergency behavioral health condition, that those symptoms are either a medical mimic of a serious medical condition that is looking like it's psychiatric, but it's actually a medical condition, like say low blood sugar, or somebody who is anemic, or somebody who has just had a seizure, or they've had head trauma, or they're having withdrawal. All those kind of things can look like psychiatric conditions, but they're actually medical conditions, and sometimes they can be life-threatening. So we really need to rule those out. And one of the things that's important, if somebody's coming to the ER with what appears to be a psychiatric condition, your people doing that initial triage, that initial evaluation, please don't say, oh, it's just psych. You can go sit in the corner and wait for somebody to come help you, because there's unfortunately too many really terrible tales of people who everybody thought it was just psych, who had a really bad outcome because they didn't get intervention when they needed it. And it turned out they had like bleeding inside the brain, or they had a problem with something that was in their blood that, a simple evaluation would have ruled that out. And hopefully we won't want to do that again. So what that means is that no matter where your location is that you're doing psychiatric crisis, psychiatric emergency work, you need to be able to have somebody who can at least do a good once-over evaluation, get some vital signs, look at somebody's eyes, see what their skin condition is like. If you are able to just do those basics, you're going to be able to determine whether or not somebody is having a psychiatric emergency or if they're having a non-psychiatric medical emergency, and you can move them over to that medical side and get them the care that they need. But once we've determined that somebody does have a psychiatric emergency, the next step is that we want to rapidly stabilize that acute crisis, the whole reason they're there in the first place, the fact that they're having the worst day of their lives, and it's just awful. And maybe they're suicidal, maybe they're feeling like they want to hurt others, maybe they just don't even know how they can get through another few minutes. Those are really, really serious conditions that all of us want to help as quickly and as well as we possibly can. But historically, there has been this kind of just psych idea where when somebody's coming into the ER, you know, somebody who comes in and there's been a plane crash, or they're having a heart attack, or they've had severe bleeding and they might lose, you know, a foot or something like that. Obviously, those are serious, serious issues that are super emergent, and we want to help those people as quickly as possible. Nobody could ever argue with that. However, psychiatric emergencies are serious too, and maybe they're not as serious as the plane crash or the heart attack, but they're up there in that next level, and they need to be intervened in at that next level, with people coming in with small bowel obstruction, let's say, people coming in with infections, people coming in with lacerations. The psychiatric emergencies should be thought of at that same level of care, that these are people who are suffering. They're having a difficult, awful time. They need our help right away. And we should not be telling them, have a seat and we'll see you in a few hours, because they're suffering. They're in a lot of suffering, and we really need to be able to help them out. So I've spoken to a lot of people. I work for an organization that's mostly emergency medicine doctors, and there's like 4,000 ER docs in 28 states and about 900 hospitals. And so those are my colleagues. Those are the people I work with every day. And by and large, they're very, very supportive of the idea of we need to do better care in the ER for behavioral health emergencies. However, I've been told by one of my colleagues who said, well, Scott, you bring up some great points. However, we don't have a blood test that shows somebody is having a behavioral emergency. And you know what? We don't have an X-ray that we can do to show somebody's having a behavioral emergency. So how about that? Maybe that means they can wait longer, because we can't prove they're even having it. How do we even know they're legit? And my response to that is, yeah, you're right. We don't have a blood test. We don't have an X-ray to show somebody's having a behavioral emergency. You know what else? You know what other emergency that we have that we don't have a blood test or an X-ray to prove? Pain. And pain is very real, and we all understand what that's like. And we know how awful serious pain can be. And if you come into the ER with serious pain, nobody's going to say like, well, sorry, we don't have a blood test or an X-ray, so you're going to have to leave. No, you go like, oh my gosh, pain. I know what pain is. I want to help this person with pain. So maybe think of a psychiatric emergency as the equivalent of the worst headache you've ever had in your life. And imagine coming into the ER and saying like, wow, my head is splitting. Please, I need help. It's like I was hitting the head with an axe. Please help me now. And you wouldn't want to say to that person, okay, fine, let's go sit in the back and somebody will be by to see you in 4 to 6 hours. No, you'd be like, oh my gosh, that's serious pain. They need our help. I understand that. I empathize with that. Let's get that person the help they need so that they aren't suffering any longer. And maybe we need to think of psychiatric emergencies in that same way. And then when we are going to intervene in psychiatric emergencies, we need to do things differently than we've historically done in the emergency department. Unfortunately, most psychiatric emergency care in ERs historically has been done using a lot of what we call coercion. There's been a lot of people being physically restrained to beds. There's been a lot of forcible medication, injecting needles into usually like somebody's bare hip. It feels very like almost like an assault. You tie somebody down to a bed, you pull their pants down, and staff hold you down when you put 1, 2, maybe even 3 needles into somebody's bare bottom to heavily sedate them, not even really treat what their problem is, what the reason is that they came there, but just like it's almost like they're thinking you're a problem and they want to just heavily sedate you and knock you cold with this coercion and physical restraints, involuntary medications. Those are not good things. There's a very, very, very rare situation where maybe you need to do that. And so there's still a possibility that probably the system is going to hold out if absolutely necessary. But our goal is, let's do that as little as possible. Let's make that like 0.0001% of the times that we see folks. And instead, let's form a therapeutic alliance. Instead of being, I'm the doctor, you're the patient, you do what I say, it should be, hey, you're going through a tough time. Let's get you through this together. Wouldn't that be great? And then when you do that, maybe people will be more willing to see that you're not their adversary, you're not the bad guy, you're actually somebody who really cares about what's going on and really wants to help you. And maybe that is going to make getting through this worst day of your life a little bit better. And one of the ways we can do that is doing what we call treat in the least restrictive setting. And this is a big difference for a lot of our colleagues in emergency medicine, because they've been trained to think that if somebody with a behavioral emergency comes to the ER, that the best thing that they can possibly do for them is get them into an inpatient psychiatric hospital. And so there's some problems with that. I mean, I work in a hospital. Maybe some of you in the audience work in hospitals. Maybe most of you, I certainly haven't asked what your day job is. But I love my job in the hospital, and I love working there. You know what I wouldn't love? Being locked into the ward that I work in and not be able to leave and having to sleep in that bed and be there for 24 hours a day for the next 10 days. That doesn't sound very fun. That sounds kind of restrictive. And our idea that the best way we can help our patients is to put them into the situation, like lock them into a small psychiatric ward, is the best thing we can do for them. Maybe wouldn't it be better if we could help them get in good enough shape so that we can get them back home where they feel safe and comfortable? We have a solid follow-up plan that means that they're not going to get into crisis again, but they're able to come and go as they please. It's somewhere they feel safe and comfortable. They know that there's, their favorite kind of soft drink is in the fridge, and that they can put their feet up on the ottoman and watch their favorite TV show. How much different is that than being stuck in a hospital? And how much better is that you can do things from the comfort and safety of your own home? So being at your own home, feeling safe, feeling comfortable, willing to engage in treatment from that level of care, that's the least restrictive setting. Most restrictive setting would be in physical restraints. Next to that, as the most restrictive, would be locked into a psychiatric hospital. So wouldn't it be nice is that we could always go towards that least restrictive, that our goal in doing really good emergency psychiatric care is that we can get you back home where you feel safe and comfortable as quickly as possible. And that's a big difference than what emergency docs are used to. And some of what we've been trying to teach them is that, no, the best thing you can do for them is not find them an inpatient bed. The best thing you can do for them is intervene now, help them with their crisis, get them through that worst day of their life today, and then hopefully get them back home where they'd much rather be than locked into a hospital. And if we're able to do that and get them back home and promptly, because we did emergency psychiatric intervention, we want to make sure that we're not just giving them a pamphlet that says, here's some phone numbers, call somebody if you need them. But no, we actually intervene, and we do a really good job of setting them up with follow-up care, that we make sure that they have an appointment. If they are already fortunate enough to have a case manager, outpatient psychiatrist, they just went through crisis, they've been in our facility, we call them up and say, you need to see this person tomorrow, and can we get an appointment for them? And so part of our discharge is making sure they've got follow-up with that outpatient provider they're already hooked in with. If they're not already hooked in with it, let's get them an appointment as quickly as possible to get them into the system. And let's make sure they have somewhere safe to go. And that's a place that they want to go. And so what we usually think of is that when we're working with a psychiatric emergency, the first half of our time is figuring out how we can stabilize and get somebody in good shape and change them from an emergency patient into an outpatient. And then the rest of our time is, how do we make them into a situation where they're in a good outpatient world, that they're not going to get into crisis again? And you remember that I was talking earlier about people saying, how can we find ways to prevent crisis patients from coming to the ER? Let's create a program so that people don't go to the ER. And again, good programs. However, what I think of is that when somebody's severe enough so that they go to the ER, Let's not try to prevent them from going there in the first place. But once they come to the emergency department, let's do such a great job that hopefully they don't get into crisis again and they don't have to come back. And wouldn't that be a great way to reduce the number of people using the ER, is that when they do use the ER, we do such a great job that we keep them stable, we put them in a good situation, and that's why they don't have to come back, because they don't go into crisis again. Next slide. So that leads us to the EmPATH model, as we've been talking about. And EmPATH, as I said, is an acronym. It stands for Emergency Psychiatric Assessment, Treatment, and Healing. And there's several nice things about the acronym. For one, the obvious is it sounds like empathy, which is something we should have for anybody going through a behavioral health crisis. Another way of looking at it is it's the emergency path for people with behavioral emergencies. This is the pathway you're going to go through when you get the care that you really need. Or then we could break it down into what exactly stands for each letter. And what's neat about that is it's actually the direction of care that you get. When you come into an EmPATH unit, you get an emergency psychiatric assessment, and then you get prompt treatment, and that treatment is hopefully going to lead to healing. So it actually even goes in that direction. And it's based on the idea from years of research that shows if you use the EmPATH philosophy, if you follow the EmPATH model, 75–80% of people who come into ERs with a severe psychiatric emergency get better and can go home in less than a day. So how does that work? What is different about EmPATH? Well, for one thing, it's the designated destination for everybody coming to the ER with emergency psychiatric symptoms. So EmPATH is not like an alternative destination to inpatient. It's not somewhere that if you come into the ER, a professional will come and see somebody and say, okay, you can go home. You need to go to inpatient psychiatry. You're in the middle. You go to EmPATH. That's not what it is. EmPATH is a separate ER specifically for psychiatric emergencies, that if you come into the main general medical ER and you're having a psychiatric emergency, we want you to move as quickly as possible from there into the psychiatric emergency program, the EmPATH unit. And you might say, well, why would we do that? We don't do that for any other patient coming into the ER. And I'd say, wait a second, though. What if you go to a nice community general hospital and it's 3 in the morning and there's only one door into that hospital, and that's into the intake area of the ER. Very, very common. Most hospitals in this country probably work that way. So let's say it's 3 in the morning and you come in and you say, hi, I am feeling contractions. I think I'm about to have a baby. Would they bring you into the ER and then have somebody come down from labor and delivery to come and do a screening evaluation on you to determine whether or not it's appropriate for you to go to labor and delivery? Or would the ER doc say, wow, look at you, congratulations, let's get you up to labor and delivery right away? Yes, that's exactly what you would do. And it's very similar with EmPATH. If you come into the ER with a psychiatric emergency, a quick once over, and somebody can say, you know what, we've got a great opportunity. We need to get you over to the EmPATH unit. Just like if you're about to have a baby, you don't want to deliver it in the ER. You want to go to the labor and delivery unit where it's really set up for you. Well, EmPATH is really set up for you if you're having a psychiatric emergency. It's designed and staffed to treat all the psych emergency patients. You saw that slide I had before where there's 14 different kinds of patients that usually are unfortunately too acute or too medically compromised to go to a standard community-based counseling or drop-in urgent care psych program. What we want to do even on top of that is minimize any reason we wouldn't take somebody in EmPATH. This is going to be an extension of the ER. So we shouldn't be saying, well, we can't take that person because they have diabetes or their blood pressure is a little high or something like that. No, we want to get everybody moving over. We know that we're in the hospital near the ER. So anybody having a tough time, we can get our ER colleagues to come over and help. And so we can be confident taking somebody with a little bit more medical acuity than maybe if we had a standalone counseling center 10 miles from the nearest ER. That would be a little frightening to have that kind of patient of concern. We can be a lot more accommodating in an EmPATH unit because it is working in tandem with an ER And we're their labor and delivery unit. We're their more appropriate place for behavioral emergencies, just like labor and delivery is the more appropriate place for people who are about to deliver a child. The other thing that really makes it work is once you get to EmPATH, you're going to be seen by a psychiatric provider within minutes after arrival. A psychiatrist, a psychiatric mental health nurse practitioner, a prescribing provider is going to see you. Usually the goal is in less than 60 minutes after arrival, because we know we only have 23 hours in the EmPATH unit because it's considered outpatient emergency care, observation care. We've got 23 hours to work with you. So we don't have time to wait until the doc stops by later today. You need to be seen right when you come in, because you're having that worst day in your life. We don't want your suffering to go on a minute longer than it has to. So that means the doc, the provider needs to see you right away and then start a treatment plan as soon as possible. And hopefully that treatment plan is going to mitigate all those unfortunate, unpleasant things that are going on for you today. But what we're going to do differently than the traditional thing is that when that provider sees you, they're not going to just make a decision, you need inpatient or you go home. No, we've got that 23 hours to help you. So instead of that, let's start a treatment plan. If meds are indicated, let's start meds. Meds aren't always indicated, so maybe we don't start meds. But whatever we do, you're going to be in this really therapeutic, home-like, comfortable environment that is the EmPATH unit. And we're going to be able to work with you, and we're going to start relieving those symptoms, and we're going to intervene right away. And too much of historic treatment of psychiatry and even the whole boarding concept is hurry up and wait for a couple of days. And you're suffering all that time, but you're not going to get any help for a day or two. In EmPATH, that help is going to start within minutes after arrival. And instead of us trying to say, we're just going to medically clear you and send you to inpatient, no, we're actually going to start treatment, and we're going to hopefully do such a good job that you don't need to be hospitalized. This is all going to take place in this really lovely, therapeutic, home-like environment called a milieu, which is completely distinct from the medical emergency department and really based in a wellness and recovery approach. Next slide. So the physical space of an EmPATH unit, the basic idea is that EmPATH is really one large big room. It's often oval shaped or circular shaped, but any kind of large room where everybody comes in and the whole room is a place where you're going to be getting your care and you're going to be getting help, and it's a supportive, therapeutic, but also nice and comfortable and home-like environment. The design is that everybody comes in, there is a large open space, there's a number of recliners around. You can come in and pick which recliner you'd like to spend the next few hours as your own. The recliner can sit up, where you can engage in one-to-one therapy or participate in group therapy, but you can also fold it down and it becomes flat and becomes like a bed. And you can go and get yourself a pillow and a blanket because you have open access to linens. You don't ever have to ask or beg a nursing staff member to let you have linens. No, you can go and serve yourself. If you want to take a nap, that's great. We know that sleep is curative. But there's also got to be plenty of space in this milieu area. So we have figured out from national guidelines that every patient should have a minimum of 80 square feet of space. And just a part of that is around that recliner. We're going to do the social distancing and make sure that there's 6 feet in every direction from you. And that means kind of like a 36 square foot halo around each recliner. But to get to 80 feet, that means we've got another 44 feet. Where is that? So that is that there's plenty of space so that you can move around. Some of our folks, when they're in a crisis, pacing or helps them out, or maybe doing yoga or stretches or things like that. We're going to give you plenty of room to do that. We're also going to have a space where you can sit and watch TV or read a book or sit at a table and play cards or dominoes or a board game with other staff members, other patients, maybe a peer support specialist, anything that makes it feel like safe, comfortable, familiar. You're going to be able to do that. And what's really nice about being able to be in that situation is everybody's in the same room together, including the staff and the nursing staff. So everybody can have this kind of gentle, direct observation over everyone who's in there. And it also means that We are far less worried about the ligature risks that the Joint Commission is so concerned about, because everybody's under direct observation. So nobody's going to really be able to do anything to harm themselves, because you're going to be right there and you can intervene. The only place we really worry about ligature safety is in the bathrooms or any place that our patient colleagues would be when we can't see them directly. So you might say, like, wait, these are high acuity patients. The kind of patients who go to EmPATH are the ones who came to the ER, who consider danger to self, danger to others. Aren't these people going to be violent and aggressive and fighting and all this stuff? And yeah, when the first EmPATH units opened up, people were really worried that was a condition. But some of us who'd worked in emergency psychiatry for years knew it would be the opposite. Indeed, people really respond to this more soothing, comfortable environment. And rather than it being a place where people are shouting at each other or getting in fistfights, it's also instead one of the most quiet, calm, mellow places you've ever been in your life. There's something magic about the design that allows people to feel relaxed, to feel safe. Their needs are met. There's no reason for them to get into arguments or shout or be combative. And so because of that, we find that the same population who, if they're in the regular ER, 20 to 30% of them would end up in physical restraints and forcibly medicated. That same exact patient population, the high acuity psych emergency patients, you put them in an EmPATH unit, we talk about 1 or 2 out of every 1,000 needs restraints. So typical ER, 300 out of every 1,000. EmPATH unit, 1 or 2 out of every 1,000 needs restraints. How much better is that? How much better an outcome is that? So how does that work? Since the staff are all intermingled, they're not behind that typical nursing station where they have to speak through a speaker and there's this thick bulletproof plexiglass that's surrounding the unit. And there's like, here's our staff and here's you patients, and it's separated. We looked at all the research and we saw that those kind of units, although the staff will tell you they feel a lot safer because they're on the other side of the fishbowl, if you look at the research, there's far more incidences of agitation, aggression, violence, staff getting attacked than it is when it's all open. And it seems counterintuitive to the staff, especially, wait, these same people who might be dangerous to us, and we're going to take away the barriers, we're going to take away the barricades, we're going to be in there intermingled with them. How could that possibly work? And it's actually because you're intermingled, you're not separated. They don't see you as distant or that you're like special or something that they have to fight to get your attention. No, we're all in this together. We're going to get everybody through this. These are people just like you and me, and we can help them. We don't need to be separated from them. That's going to be scary, frightening, or even insulting to them. Instead, let's be in there with them together. And when they need help, they can ask for it. And we're going to see what's going on. We can keep an eye on things just in case there's anything a little bit of concern, but most often it's not, because people feel safe and comfortable and they're appreciating the help that we're giving, and they're more willing to do things like engage in treatment. If meds are indicated, they might be more willing to take them with a pill and a cup of juice as opposed to being held down and injected. If there's people who do have a little bit of trouble and they need a little bit more intervention, rather than that old-fashioned way of having the staff come and tackle them and put them into physical restraints, the staff can recognize far earlier that somebody's having a tough time, and they can go and start doing voluntary verbal de-escalation and calming techniques. And if somebody needs a little more, rather than having those seclusion and restraint rooms, locked facility things around the corridor, we have unlocked calming rooms where people can go in there voluntarily and get a chance to decompress. If they need to be out of the main room in the milieu, they can go in there and help them to feel more in control, to help to calm down. There's wonderful different versions of the calming rooms we've seen. Somebody just lectured at the conference yesterday from the University of Minnesota, where they've created calming rooms that have beanbag chairs in them, and there's dials on the wall, so you can change the lighting intensity, you can change the lighting color, you can change the sounds, you can have like nature sounds or waves or all kinds of stuff, or you can have nice music and playing it loud or kind of soft. Anything that helps you get it back together and feel better is going to make everything safer for you, and make it safer for the other patients, and make it safer for the staff. Thank you. Next slide. So here you see a photo of some of the units around the country. And what's neat is that we've seen these in academic centers, small community hospitals, big urban environments, and remote rural environments. And we tend to see the same great outcomes wherever you go. And you can kind of see from the photos here that there's this spaciousness, there's a high ceiling, there's windows with natural light. There's plenty of room for you to walk around without anybody saying, hey, get back in that space or I'm calling security. No, if you want to walk around, great. That's what makes you feel better. We've got space for you. And we want you to do what you think you need to help get better. So you can see the nursing station's open. Anybody can approach it and talk to one. You can see the recliners are kind of big and comfy. You know, it's not ideal. You wouldn't want to stay in that for a week or so, but for the 12 to 16 hours that EmPATH usually takes, that's a much more comfortable thing than a plastic molded chair in the waiting room of the ER. So there's a lot of good things set up in this. And you can see, if you've ever been in a regular medical hospital ER, you can understand how different this is. Next slide. We have all kinds of different folks working in EmPATH. As I mentioned, you're going to have a psychiatrist or a psychiatric provider, which might be a nurse practitioner, a physician assistant. We're also going to have registered nurses, but also very important therapists, social workers, different names in different states, but it might be what you'd call a psychiatric tech, a psych assistant, a mental health specialist. And we also love having peer support specialists. And for those of you who are unfamiliar with peers, these are people with lived experience with mental illness who've gone through a training and licensing process. And they're so wonderful that they can work with somebody coming into EmPATH and say, wow, hey, you're going through a tough time. I've been there too. I've gone through the same thing. Let's get you through this together. They're worth 10 times their weight in gold. Next slide. And although, as we said, medications are an option, if that's what's indicated for somebody in EmPATH, there's also people who may be able to get through this crisis through motivational interviewing, through different therapeutic techniques, to having some ability to get away from it all, to being in a supportive and positive space with understanding professionals who are experienced in what's very common, what's going on, and help you understand that you're not alone. This is a time that we're here for you and we're going to get you through this. And there's a light at the end of the tunnel. And let's really focus on that. Maybe it's not meds, maybe it's something else, but we're going to help you get through this bad day. And when you leave here, you're going to be in much, much better shape. And that's something we can all work towards. Next slide. And that may even include respite. There's areas in EmPATH units where people can do mindfulness and meditation. Some of the EmPATH units, like we showed in those pictures, have outdoor healing gardens where patients can go out and sit and get some fresh air and look at the sky and feel like there's a big world out there of positivity and really get through this tough time. And so whatever it is that any individual needs to get through the crisis, we're trying to provide an environment that's supportive of that makes it feel safe and healing and just in such a positive, wonderful way that we're all thinking, by the time you're in a different shape from now, 12, 16 hours from now, we're going to see you have gone from a very, very unfortunate situation to a smile on your face and you shake our hands and say thank you. And that's all we need on our end to feel like we are really doing the right thing and we're doing the right place. And we're so happy that we're able to help you get through that difficult day and go from despondent to positive and optimistic. Next slide. So if we think of just like writing a list of what's the patient benefits compared to current state that we see in most hospitals around the country, if not the world, we're going to have a trauma-informed unit that's much more home-like. We know that the average emergency department is noisy, scary. There's uniformed personnel running around. You often can't find out from anyone what's going on with you or what's going to happen next. And it can many times make your symptoms worse and make you more frightened or paranoid or despondent, even make your psychosis symptoms worse. We're going to get away from that and put you in a completely different situation, which is much more beneficial, therapeutic. You're going to go from that kind of unfortunate situation to one where you're in the right place with the right personnel at the right time, and you're ready to get better and start healing. So you're in this calming environment that really meets your needs. You don't ever have to ask anybody for linens. You don't have to ask anybody for something to eat or drink. There's a snack station. You can go up and grab yourself a little something to eat, get yourself a beverage. There's still going to be regular meal times, but if you're hungry, you know, we want to make sure that you have food to eat. If you're cold, you can go and get yourself a blanket. If you want to like take a nap, you can get a pillow. You know, nobody has to like interrupt the nurse who might be busy, and then you feel bad and the nurse feels bad because you can't get that thing. No, you can serve yourself what it is that you need. And that's a complete difference than the traditional psychiatric intervention. As I mentioned, there's a multidisciplinary team. The difference is that we're also not having somebody visit, take a quick snapshot and say, this person needs to be hospitalized or this person goes home. Instead, the great majority of our patients, we see them, we initiate a treatment plan, and then we see how you respond to the treatment plan. Most EmPATH units are set up with a maximum stay of just under 24 hours. So what we try to do is see the person very quickly, start a good treatment plan within an hour after arrival, and then we have 8 to 10, 12 hours to see how you respond to that treatment plan. And it maybe if it isn't working so well, we adjust it, or maybe change the medications, or change the interventions, or get somebody more involved that might be helpful. But right around that halfway point through the 24 hours, we change it from, you know, what's the treatment plan to how do we get to the next level? If you still look like things aren't getting better with our treatment plan and you need hospitalization, that's okay, but let's start finding you a hospital bed. If you are on a path towards getting much better, let's start you on a path where we're going to get you connected to your outpatient doctor. Make sure you've got an appointment tomorrow. Make sure that you're going to a safe living situation. If you don't have a safe living situation, let's work to find you one. If you don't have an outpatient doc, let's get you one. Let's get all those things. What we recognize is that when we change an emergency patient into an outpatient, the best thing we can do is get you plugged into a good situation, and then you're hopefully not going to get into crisis again, and you won't need to come back, and then we've done a great job. As I mentioned too, the restraint use on these units is incredibly low, usually 1 or 2 out of every 1,000 patients. Next slide. It's good for the hospital in many ways just as well. It follows that EMTALA law that they need to see everybody, and they're doing it in a much better way than saying, oh gosh, I wish there was somewhere else these folks could go to. These are our patients. Let's do the best job we can for them. But in that being said, a lot of EmPATH units were open during the pandemic because people were looking at their ERs and saying, we have a COVID wave that's really intensifying, and 1/3 of our beds are filled with people waiting for transfer to a psych hospital. That's terrible for these patients who aren't getting any treatment and they're stuck in these beds, but it's also bad for everybody who wants to come in to the ER and wants to be seen by a doctor. They can't get into those beds because they're unnecessarily being held up by these folks that, gosh, I wish we could be doing something more for them, but we don't have anything. And so instead of having people stuck in those beds, how about we move them to EmPATH where they're going to get better and more prompt care? And then those beds open up for other non-psychiatric medical emergencies like COVID patients, and we've got space for them. The other thing is this is even good for inpatient psychiatric hospitals because they're used to getting referrals from medical ERs of just a chart and saying this person needs to come to your place. Do you have a bed? Change that to they've been in EmPATH. They've had a comprehensive eval. They have a documented 16 hours of treatment that you can see how their response is. You can see that we've already vetted them, that if we're referring them to you, we've tried all alternatives, and it appears at this point they need to be hospitalized. So that's going to mean that no insurance company, Medicaid or Medicare included, is going to deny you payment because we proved that they need your level of care. And that's going to make these people more attractive for admission to these inpatient hospitals. And so we're going to make the whole system that much more efficient, that we're going to get people the help they need as quickly as possible, great interventions in the right environment with the right personnel. And for those small percentage, 20, 25% of folks remaining who still need to be hospitalized, we're going to make sure that that inpatient hospital sees you as somebody that they want to admit as quickly as possible. And because we're not referring nearly as many patients as we would have in the past, hopefully there's going to be more beds available when we do make that referral. And so it's going to be literally a win-win, win-win-win across the board. Next slide. So what's neat about EmPATH in general is that the model's really only been around for about 8 years now, but it's become so established that the FGI guidelines have a whole section on EmPATH units now. So FGI, you may not be familiar with these, but that stands for Facility Guidelines Institute. It was something created by the US government back around the World War II times. That was to create the national standards for healthcare programs and hospitals and their construction, design, licensing, all those things. So almost every state in the USA uses the FGI guidelines for your things like who you have to go to if you're going to remodel a part of your hospital or build a new hospital, whatever your agency is that does that, their standards come from the FGI guidelines. If you're looking for a new license or if you're looking to redesign part of your hospital, whatever agency you're going through or whatever decisions you're making, your architects are going to use the FGI guidelines to do that. So the FGI guidelines have been around for about 80 years, and they come out once every 4 years. They do a complete rehash updating once every 4 years. This year being 2022, I guess like the World Cup is the year that the new FGI guidelines comes out. And the quadrennial 2022 edition of FGI has EmPATH units for the first time. They refer to them as any psychiatric emergency program in a hospital, they refer to as a behavioral health crisis unit. But then they also have a large subsection, and the one they paid the most attention to is what they call the multi-patient observation behavioral health crisis unit, which is another term that is a little more official sounding supposedly, but kind of a mouthful, but that's what they're calling the EmPATH unit. And they've been very clear in interviews with the press and promotional things they've done that they have really done this, and this is the EmPATH unit that they're describing, and they wish that tons and tons of hospitals would open up EmPATH units, and it's one of the goals from the new FGI edition is to set those parameters, set those guidelines so that hospitals will be interested in opening up these much needed units. Next slide. So here's some quick things about what's happened with these units being created around the country. Next slide. So you see that this model has, like I said, it's only a few years old, but it's already expanding all across the USA. And there's a number of them in many states. And this is actually showing all the places that they're either have an operational EmPATH unit now, or they're in the middle of creating one that should be open within the next several months. And you see that we have that big space for Ohio that has no stars in it right now, while we've got 2 in Canada right above it. We would love to be able to create these in Ohio. And in fact, I know of a hospital system that would really like to open one of these. So hopefully, if you think anything that I said today is interesting, that maybe we can work to get Ohio this model as well, because we've just seen amazing things, and we'd like to see this more people across the country have access to a program like this. Next slide. So one of the most prestigious journals in medicine and emergency medicine is called Academic Emergency Medicine. It's probably one of the top 1 or 2 medical journals in all of emergency medicine. They published an article on some study of the University of Iowa's EmPATH unit. Originally was published in August of 2021 online, but then in their official print journal, it was their #1 article in February 2022. They said it was their editor's pick because it was so impactful, and they even did a whole podcast about this study. Basically what it was looking at an EmPATH unit at the University of Iowa's hospital and clinics, and compared the situation in their general medical ER 6 months before the EmPATH unit opened compared to 6 months after the EmPATH unit opened. So about a year difference in time before and after. And here's what the amazing differences they found were. that they reduced the overall length of stay of patients coming in with emergency behavioral health conditions in their ER from over 16 hours to under 5 hours, a 70% reduction. The number of people who needed to go to inpatient after EmPATH compared to directly from the ER dropped by well over 50%. Then here's some really neat things that maybe somebody hadn't even thought of before, but maybe they did such a great job in EmPATH that they changed our clients, our patients, way of looking at things, in that they were more eager to seek help and to follow up with their outpatient appointments after discharge from EmPATH than they even were after discharge from inpatient. So the outpatient follow-up in this study showed that people who had been admitted from the ER to inpatient, that about 39% of them made their first follow-up appointment. And compare that to people who were discharged from EmPATH, almost 2/3 of them showed up for their outpatient appointment afterwards. It's just an amazing difference. And I think it has a lot to do with just people feeling more positive about the system and having gone through that worst day of their lives, but actually been with a caring team that worked in a very comfortable and home-like situation. Maybe they're like, in the past, they might have thought that mental health professionals were their adversaries, but now it's like, wow, I had a good experience there. I think really those people care about me and they want good things to happen to me. So maybe I should follow up with that outpatient appointment. Maybe that's why so many more people end up going there. The other neat thing about that is that there was a check on all these patients. If they came back to any ER for any reason in the 30 days after discharge from EmPATH, and maybe some people would say, oh, you're not holding them long enough, they'll just be back in a couple of days. Well, actually, it's just the opposite. The number of people coming back to the hospital ER decreased by over 25% compared to the previous situation. It also found that there was shorter lengths of stay when those people who were in EmPATH went to inpatient, and that they actually had a much better numbers in terms of their financial bottom line for the ER, because they're able to move those patients to better care in EmPATH and then open up those beds for non-psychiatric emergency patients. So it was a win-win-win-win-win across the board. Next slide. The one at the University of Minnesota Fairview Hospital has just it's a gorgeous unit, and they've had a lot of media attention. This actual photo was a promotion from an ABC News story about this unit, and showing that at that time, this story was from about 9 months ago, that they were only admitting 17% of the patients that used to be 100% of the people they'd admit. And we just heard them present yesterday at the conference that I'm at, they're now down to only 14%. So imagine, out of people that 100% previously would have gone to an inpatient unit and been there for several days, now they're back with their home, with their loved ones. Yeah, and just like, 14% of the ones still needed inpatient, and that other 86% got to go home in less than a day. What a game changer again that is, compared to the way we've done things historically. Next slide. So there's also, you can regionally look at EmPATH where maybe one hospital or one center becomes the EmPATH unit, and other hospitals in the area can then refer to there. And you can use kind of a hub and spoke approach where you might have a hospital system of 4 or 5 different hospitals in a region, and one of them creates EmPATH, and that if you come to any of the ERs from any of those hospitals, they can move the patient to EmPATH rather than be stuck there again and waiting for inpatient. Let's get them right to the proper level of care, almost like a trauma center model, where you've got a number of ERs and one has a higher level of care for more severe trauma. We can have a number of ERs and they can all send to the one center for EmPATH. Next slide. So a great example of this, and about as remote as you can get, is Billings, Montana, which is a fairly good sized city for Montana. It's about 100,000 people, but you go 100 miles in any direction outside there and you see a lot of beautiful trees and mountains and not a lot of people. But they're able to, just as we've seen in those academic hospitals or in downtowns of big cities, remote area like Billings, Montana, they opened up a EmPATH unit, 2-sided EmPATH unit separated units with a centralized nursing station. One side was for adults, one side was for child and adolescents. They've been open for 4.5 years now. They're only averaging like 1 or 2 of every 1,000 patients goes into restraint. They've saved tons of money for the hospital. They're actually showing that the number of people coming back has gone down by 50% because they're doing such a good job stabilizing folks and changing them from emergency patients into outpatients. And the length of stay in their ER dropped precipitously as well. Next slide. So the opposite of Billings, Montana would be a huge urban city like Los Angeles, California. There's a gorgeous unit there at the hospital called the Providence Little Company of Mary. They've been open for 5 years now, and they are actually able to stabilize and discharge 81% of the patients they see, which almost all are coming in on a hold in California, which is known as a 5150. Normally 5150 patients were just coming to hospitals, and that was just a short stay to get their medical evaluation until they could send them to a psychiatric inpatient unit as their only real destination, because the ERs weren't able to discontinue the 5150s. All they were able to do was help them get on their way to the next stage. But as we've been mentioning, sometimes that get on your way to the next stage took several days. When you have an EmPATH unit, you have professionals that can discontinue those involuntary psych holds. And so you see at this hospital, the Little Company of Mary, that 81% of the people on involuntary psych holds, they were able to discontinue that and get those people home, and something that wouldn't have been possible in the old model. Average length of stay, as we mentioned, right around 16 hours. Again, 2 out of every 1,000 patients goes into restraints. Just amazing changes, and such for the positive. Next slide. Another California hospital, another near an urban setting, is near the California capital, Sacramento. And this was a place that has always traditionally seen a lot of psychiatric emergency patients. And what's been fabulous about their situation is that they had so many folks in the past and they had nowhere to send them, that they actually had one back hallway that they were just stacking folks up on gurneys. And they were calling it their hall of shame. Their average patient there was staying about 33 hours untreated, strapped to a gurney. It was a terrible situation. They opened up an EmPATH unit. Within the first month, their average ER length of stay went from 33 hours to 19 hours. 2 months, it went down to 7.5 hours. That's a 77% reduction. I just met with the person in charge of that unit who's here at this conference yesterday. Their average ER length of stay now is 2.5 hours compared to 33 hours that it was before EmPATH. And once the person is considered ready for EmPATH, they move over in less than an hour. 80% of them end up getting better and going home. But here's something we haven't talked about, and something they do. They have a really good patient satisfaction survey. They found that on average, 85% of the people that they see said it was a great experience and that they really appreciated it. And if you think that what most of these people were being brought in handcuffed in the back of a police car, and if that's the start to your day, that you're handcuffed in the back of a police car and brusquely treated like you have to do the perp walk and you're a criminal, and you're brought into EmPATH and you leave saying, I had a good experience, that's amazing. Because how many times would you say you had a good experience when your day started with handcuffs in the back of a police car? But they're able to do this at that's wonderful EmPATH in Sacramento. And again, they dropped the number of people coming back within 30 days by over 30%. Next slide. So one thing I want to make key, and we know we have Travis coming up after me with those wonderful community options. Think of community crisis services as a spectrum, and you need mobile crisis. You need people who are working with the police department. You need crisis residential. You need drop-in crisis care, voluntary counseling, all these other things. EmPATH is not intended to solve any problems or replace anything. It's for this one missing link that unfortunately has been there, where we either have a great community system, but then once you get to the hospital, all we're going to do is send you to inpatient. We're filling that void, that crisis care should not end at the hospital door, but instead we know that we can get great outcomes if we do interventions at the hospital. So this is just intended to be one link in the overall crisis system, not to replace anything, but to complement the system, and with some really good good effects for that high acuity population that's really a bit too much for the other parts of the system, just like we wouldn't expect for somebody who's been in a plane crash to go to the Walgreens Minute Clinic. You need a higher level of care for somebody like that. It's the same thing with EmPATH. And so we really want to think of this as a complementary system, which is a really good thing in that regard. So since 988 has come out, a lot of people have been using a white paper manual from the National Council for Mental Wellness, which is called the Roadmap to the Ideal Crisis System. And that specifically says it's a 200-page manual about how we should be approaching 988 and all these crisis patients. They recognize that EmPATH is part of that complement, a part of that spectrum of crisis care. And they say there should be at least one EmPATH type unit in every regional mental health system. Next slide. So if you're even looking at, and we talked with Ohio Medicaid leaders about this the other day, if you're going to see the number of patients who traditionally would have gone to psychiatric inpatient, that's an expensive stay when you get to psychiatric inpatient. Typical cost of Medicaid for that's about $12,000. Typical cost for an EmPATH stay to Medicaid is about $2,000. And if we're going to avoid, if we just use that 75% number, which we see over and over again, whether it's urban, rural, academic, community, everybody seems to be somewhere between 70 and 80% of the patients who traditionally would have gone for inpatient hospitalization that were now getting better and are able to go home in less than a day. So that means if we just take that ballpark 75% of patients who used to go to inpatient, that means for 3 out of every 4 patients, we're only costing the system $8,000 and we're avoiding $36,000 in inpatient costs. So it's a win for the patient who gets to go back home. It's a win for the ER who's opening up space for other patients. It's a win for the Medicaid providers, the payers, everybody who it's going to be getting people better care at lower cost, more prompt care at lower cost. That one place in Sacramento I just mentioned, they did a study and they showed that they'd saved their Medicaid system $45 million in the 3 years that they'd been open, providing high quality, high patient satisfaction care. Next slide. So one thing that's really been neat just this week, 3 days ago, or actually 4 days ago now, because it's Friday, Monday morning this week, the state of California announced that a new $20 million grant program specifically for hospitals to build EmPATH units by name. There's an RFA going out this Monday of this coming week, and any hospital who's treating psychiatric emergency patients is going to be able to apply so that they can build an actual EmPATH unit, and it's actually called the EmPATH grant program. Next slide. And I want to add one last thing is I just heard that South Carolina is going to be having an EmPATH grant program as well, starting in January or February. But anyway, that's my talk. And thank you for paying attention to me. I know I had a long thing. I hope I didn't bore you, but I'm happy to answer any questions in the few minutes we have left.
Thank you so much, Dr. Zeller. A wonderful presentation. We do have some questions. I'm not sure if we'll get to all of them. So if you're able to kind of type out some answers after, I'll just go through the ones we have in order of kind of when we received them. So our first one is, can you share some information about how the EmPATH model interfaces with crisis call centers, 988 or local lines, model crisis units, or community-based crisis facility settings?
Yeah, great question. And thank you for asking that. It's like I said, it's part of the spectrum of care. And what we want to do is have people who are seeking help be able to access that least restrictive level of care. So if mobile crisis can serve them, if the crisis call can serve them, if they can go into the voluntary urgent cares, that's always like preferable. And hopefully people will go to there. All of those parts of the system, however, will know when they have an EmPATH unit available that if it's somebody who's having a bit more complicated time, a bit more high acuity medical comorbidities, that EmPATH unit's available to them. And then we want to have a reciprocal level of involvement with all those great programs so that we want to hopefully stabilize our person who's come to the hospital. and tell them, hey, next time, before it gets to this level, before you need to have police involved and all these other unfortunate things, here's a whole bunch of different possible places that you can go instead. And we know these folks, we know they're great, and we really encourage you to seek out these places again. So we're going to really work with them and hopefully have a fabulous interpersonal relationship with all these programs, and say like, hey, here's what we're going to do, and make sure that we can connect folks to you so they don't have to get to this higher acuity level again. But whenever you need us, we're here, and we're willing to work with those folks that might be a bit more difficult than what you can do at that community level.
Great, thank you. I'm going to ask one more, and I think we might have time for this one. A couple of them have multi-questions, but in the state's hospitals who have implemented the EmPATH model, is the psychiatric ED covered under the existing hospital license regulations, or have states created separate licensing requirements?
Yeah, it's actually a really insightful question, and whoever asked it, that's a wonderful question. There has been some issues in certain states, like, what is this? Where does this fall under the licensing? And what we found is that the best case scenario is usually that this falls under the what's called an emergency outpatient observation unit, which is the same thing where somebody's being observed over time from the ER for telemetry, for like ruling out a heart attack, for seeing if the small bowel obstruction proceeds. Actually, observation is agnostic to the diagnosis. So heart or belly is the same as psych in terms of the license and the space. It's these are always considered to be outpatient. That's not an inpatient unit. And so different states have a different parameters of what's outpatient. Maybe that can be up to 24 hours, maybe up to 48 hours even, but these are outpatient units under the hospital general license. And it sometimes can get a little persnickety just because the licensing agencies have been unfamiliar with these units historically. They're happy to go with the observation. The fact that those FGI guidelines that I mentioned before now have hard and fast rules and a huge document just about what they think EmPATH should be looked at from a national and state level, that we may even see some advancement in those state licensing agencies that would say, not just, okay, you've got this psychiatric outpatient observation, but actually you've got an EmPATH, and maybe they'll even start to create specific state licensing guidelines for those based on the FGI.
Great, thank you. That's all the time we have for the live. There's a couple more if you want to go in there and answer those, and I'll turn it over to Molly. Thank you again.
Thank you.
Yes, Dr. Zeller, thank you again. Echoing Elijah, it's so excited to learn more about this empathetic approach to providing quality care within our crisis systems. So as alluded to before, next is Travis Atkinson speaking on behavioral health urgent care models. Travis is the Director of Clinical and Crisis Consultation at TBD Solutions. So Travis.
Thank you, Maylee. Looks like my audio is working. I'm going to go to the next venture, which is sharing my screen. Make sure that works too. Maylee, can you see this okay?
Yep.
Okay, great. Well, I'm bringing everybody into the afternoon. So good afternoon, everyone. A pleasure to be following Scott Zeller, one of the true pioneers in emergency psychiatric care. And we're just going to get right to it. So I would like you to imagine that it's 1952 and you live in the suburbs of Baltimore. You're driving home with your partner on a fall evening along a street much like this one. As you come over the top of a hill, a deer suddenly darts right in front of your car. You slam on your brakes, but before you can stop, you hit the deer and it does some serious damage to your car. Now, unbeknownst to you, a police officer saw the whole thing happen and they drive up right behind you to check if you're safe. Once they notice that you've sustained some injuries, they say, come with me, I know a place where we can get help. And so the police officer drives you towards the city and takes you to Johns Hopkins University Hospital. and they walk you to a part of the hospital you've never seen before. You've been to this hospital, but you haven't seen this section. And you walk into this section and you see a sign over the top and it says this: welcome to the accident room. So if you were seeing this sign, you would be one of the first ever users of what we now know as the modern day emergency department. And we're going to talk about how emergency departments have evolved and iterated in different ways, and the impact that that's having on our lives today in behavioral healthcare. So good afternoon, everyone. My name is Travis Atkinson. I am the Director of Clinical and Crisis Services with TBD Solutions. I'm also the President of the Crisis Residential Association and host of the Crisis Podcast. I have been working in the behavioral health field for nearly 20 years. And the last 7 years, I have been a consultant. I started my work after my graduate degree in crisis alternatives to psychiatric hospitalization. I've worked in psychiatric hospitals. I've helped to open peer drop-in centers. And I've been fortunate to work with communities all across the country, including several in Ohio, on how to assess, improve, and develop crisis services. So my hope is that our time together today is interactive and engaging. And I would like to start that off by asking you to pull out your cell phones. And what I'd like you to do is open up your camera so that you can scan this QR code that's in the top left corner of the screen. All right, and once you've done that, you should see this question pop up for you that says, what is one word that describes your experience in the emergency department? So chances are just about everybody here today has been to the emergency department at some point. So I'd love to hear what your experience has been like. And as we get more responses, the responses that have had the higher numbers of frequency will show up larger. So it looks like it's working. We've got over 40 responses now. So the words that are showing up the most right now are long or long wait, lengthy, frustrating, uncomfortable, exhausting, scary, slow, painful, traumatic, chaos. This is great, and we'll see the words kind of continue to change as we go through this. But it's important to remember that emergency departments were created for a reason. They were created to have a centralized place to take care of people in a very timely manner. You know, prior to that accident room experience, we would have probably had to ask a doctor to make a house call. And without a cell phone, you may have to get back to your house after that car accident before you could actually get the help that you needed. So emergency departments are an important part of this safety net, along with police officers and fire and EMS. But we also have to ask ourselves, are they the most helpful right now for what is needed, considering all of the ways that people present to the emergency department nowadays? So thank you so much for putting your comments in there. They continue to come in. I appreciate that. So let's start by thinking about when emergency departments are most helpful. Okay. And we would say that it's when utilization is at that Goldilocks level. So not too much service, not too little service, but just right. So if it were too much, then triage would be difficult and people in emergence needs might not be helped. And so what I mean by that is if the volume was too high, then we would have to make difficult decisions, based on acuity, and we might not be able to help everybody at the same time if everyone is always coming to the ER. Now, if the ER is not being used enough, then what we would see is that professionals would be underutilized. There'd be too few patients to treat and bill for care, and departments might become just financially insolvent. If we have doctors and nurses waiting around to serve patients and there's nobody in the in the waiting room or coming into triage, then it starts to become pretty expensive. Now, another way that emergency departments are most helpful is when medical professionals are working at the top of their license and also within their scope. So what that might mean is that if you have a medical doctor who is not a psychiatrist or has any psychiatry training, then it might be really ambitious to ask them to prescribe psychotropic meds over and over again. Or if you have an individual who is becoming increasingly violent or demonstrating some challenging behaviors, then to have a nurse or even in some cases a technician sit with that person as a sitter is not the best use of their time. It becomes kind of an expensive ordeal, and that person who's doing the sitting isn't finding a lot of value or reward that they normally find in the other parts of their job. And then lastly, when people are seen and treated in a timely manner and their presenting conditions are adequately addressed. So I wouldn't want to wait days at the ER to, have my thumb looked at, or, I wouldn't want my child to wait for a significant number of time to determine whether his or her leg is broken. So it's quick and it's right sized. It's just in time. And this kind of brings us into this idea of modifications or improvements to the emergency department model. So it wasn't even that long of time. If you think of the 1950s as the first emergency department, it wasn't even that long before evolution started happening again. And that led us to the advent of what we know as urgent care centers. So urgent care centers are first off a healthcare system innovation from the 1970s, and it added nuance to the safety net because it required us to ask the question of where should I go? How bad is this thing that's happened to me or a family member, and where do I need to go? And so it requires a little bit more nuance, if you will. But urgent care centers, what they did is they diverted less acute patients away from the emergency departments and provided them more timely access to care. So I should actually say diverted excuse me, but it's written right. I might have read it with wrong inflection. It diverted those people who have a less acuity. It diverted them away from the emergency departments so that the people who were having a true emergency versus an urgent matter could have more of the attention of the staff. Now, that might have taken some nuances or some changes in public messaging so that people knew that they could go to urgent care centers. And I want to show you an example of a hospital system that has really done a tremendous job of this, even today, of bringing this information so that people can kind of know how to make that judgment call and know when to go to urgent care. And so, so this hospital system is called BayCare, and I'll show you what they've done on some of their billboards and marketing materials to distinguish urgent care from emergent care. I stepped on a bee would be urgent care. I stepped on a beehive would be emergency care. All right, here's another one. Hammer, hammerhead. Stepped on a mouse trap, stepped on a bear trap. I have the flu, I have the plague. So you can see that the hospital system or the urgent care system has done a nice job in this instance of helping the public to make some distinctions. And we do this so that people can receive that right size treatment, that Goldilocks level of care, not too much, not too little, just right. And I want to compare now a little bit the presence of emergency departments versus urgent care as we start to set the table for this behavioral health urgent care model. So according to the most recent numbers, there are approximately 5,400 emergency departments in the United States and over 10,000 urgent care centers in the United States. So about twice as many. The average response time within an emergency room is about 2.4 hours, whereas the average response time within an urgent care center is less than an hour. Now, some of you might look at that number and say, on the left for the emergency department, and say, I wish mine had only been 2.4 hours, but it is more than twice as much as what the urgent care demonstrates. So the outliers, like the people who are being boarded, waiting for a bed or waiting for treatment, those can certainly extend those lengths of time as well. And then the hours of operation. Emergency departments are virtually everywhere are 24/7 operation. They never close. Whereas urgent care centers often have extended business hours, 8 a.m. to 8 p.m., let's say, 6-7 days a week. And those are usually pretty transparent. There's actually an urgent care center in the Detroit area that on their billboards, they will post how long their wait is in the emergency department or in their urgent care centers. So really helpful to know and good reminders, because I think there's two things that we really don't want to do as consumers or as patients. We don't want to wait. We don't want to wait around for a long time and have something be a waste of our time or not get timely access to care. And we don't want to pay a lot. And that's the other enticing aspect of urgent care, is we understand that the bill is going to be much lower. But where do you go for psychiatric symptoms? Where do you go if you're experiencing intrusive or disturbing thoughts, suicidal thoughts, thinking of harming others with a plan, if you have a substance-induced psychosis, if you ran out of medications? Those are all important questions that we've been sending people to the emergency department and in some cases to urgent care for a long time to answer those questions, but those may not be the right places. So I just want to kind of frame a little bit how many we're talking about when we talk about these numbers. So every symbol that you see in this table coming up is going to represent 500 of an item. Okay, so here's the medical urgent care centers that we mentioned. There's about 10,000 of those. Here's the emergency departments. There's about 5,400. And just for context, I thought it'd be helpful to throw in some other some other data points of the presence of certain businesses in the country. So here's the number of Chick-fil-A's. There's about 2,900. It's lunchtime for those of you that didn't DoorDash Chick-fil-A, because I think Chick-fil-A in Ohio is only in the Columbus area. Then you might be out of luck. You might start to get angry with your presenter. That's okay. I can accept that. But there's just under 3,000 Chick-fil-A's in the United States. And then there's about 5,900 Wendy's in the United States. Now we're going to compare those to the model that we're going to talk about shortly, which is behavioral health urgent care centers. But I would love to take a quick departure, make sure we've got everyone's attention here as we're in the middle of the second session, and give you some Dave Thomas trivia. Because Wendy's, did you know, 4 facts about Wendy's. The first Wendy's opened in Ohio. It opened in Columbus, Ohio in 1969. Dave Thomas invented the double drive-through window. So before there was one window where you paid and you got your food. He put them on different sides of the building so he could have a longer food line in the parking lot, which made it seem like you got your food quicker. Wendy's is actually named after Dave Thomas's daughter, but her name is not Wendy. It's actually Melinda. And he got it because one of his other kids would reference Melinda, but couldn't say her name very well. So she'd say like Mawinda or Winda, and it sounded like Wendy. And that was the idea for the name. And then lastly, prior to starting Wendy's, Dave invented the KFC bucket. So Dave worked for KFC before he left. And if not for him, we would be eating chicken out of, I don't know, maybe like a bag or a box or something like that. So some good trivia to take along with you, good adaptability on Dave Thomas's part, certainly, that we can learn from as we think about behavioral health services. So I want to set the table for you now and talk about, back even before urgent care centers and into that time, right around when the first emergency departments were being created, what behavioral health crisis care has traditionally looked like versus what it looks like today. So when we think about that safety net again, it includes all of those providers that I mentioned, like police and fire and EMS and emergency department. And it also includes, of course, 911, which is able to dispatch many of those services. So prior to the 1970s, a person in crisis would call 911 for an emergency because that's where we were sent for everything. And then maybe they would dispatch EMS. or law enforcement, or maybe if you were out in public and you saw a police officer, you might flag them down yourself. And then you might also go to the emergency room, or EMS or law enforcement might bring you to the emergency room. And then from there, you don't have a lot of options, unfortunately. If you need more than an outpatient level of care, we're talking about a psychiatric hospital. And when the psychiatric hospital beds were full, people got really creative. I don't think that's much different today for communities that don't have much of a crisis continuum. But you started to patch together, well, what can family do? You know, is there a cousin or an uncle that could help out? Is there, can we kind of take shifts on helping this person until a bed does open up? But your options were limited, and psych hospital was the first choice. And then you made creative solutions happen after that. So in the current crisis system, we have replaced 911 or supplemented 911 with the crisis call center when a person is in a behavioral health crisis. And crisis call centers are intended to de-escalate about 80% of the people that call into that number. So people do not need to be suicidal in order to call. They can be experiencing a mental health crisis. They can be experiencing emotional distress. And I'm sure many of you are familiar now with 988, which has replaced the 10-digit number for the National Suicide Prevention Lifeline. So that is the new number that is routed to crisis call centers to allocated providers in states like Ohio and others across the country. So if a crisis call center is not able to do that de-escalation, so in that 20% window, then we see mobile crisis teams come in. And these are generally made up of some duo mix, so a two-person team of a master's level clinician, and then usually a bachelor's level case manager or a peer support specialist. We've also seen teams that have a medic that goes along. Some larger teams might have a nurse that goes along as well to be able to take care of some medical conditions. But a person in a crisis can also walk in to a behavioral health urgent care center in an optimal crisis continuum, keeping hours similar to what a medical urgent care would keep. And we'll get into the model here very shortly. But then the other options are a 23-hour observation unit, which are typically secured and locked so that they can accept anybody that comes in, and they can also accept police drop-offs. We see crisis stabilization units like those in Franklin County run by NetCare, or in Lucas County operated by Zeph Center. We also see partial hospital programs, which generally fall on the campus of a psychiatric hospital, but can kind of provide that intermediary support where you can still be okay being at home at the end of the day and on the weekends, but you really need that intensive support during the week. And then peer respite programs like I believe there are a few in Ohio. The most recent one I believe is also in Lucas County, operated by Neighborhood Properties. So we have all of these options now that we didn't have back before the 70s. And we have kind of flipped the script and said, we need to use these first, and only then if a person has, let's say, a complicated medical condition, or they really have a high level acuity, then we use those last two options. And so unfortunately, we're still living out our historical dependency on the emergency room, on 911, on police, and on psychiatric hospitals. But with these services available, we have an opportunity to make improvements. And you know, to Scott's point, we're all kind of here for the same reasons. And that is to find the right size treatment for somebody and to be the most helpful. And that also means keeping people out of restrictive and locked environments if that's not what's best for them in that moment. So I'll give you another map that just kind of gives you an idea of how many of these services exist in the US today. So there's about 800 crisis call centers, about 700 crisis stabilization units, approximately 500 mobile crisis teams, just under 200 23-hour crisis observation units, Of last count from a study in 2020 was 77 or about 80 behavioral health urgent care centers, and then about 70 peer respite programs. And I didn't really explain peer respite, but peer respite is the concept of a therapeutic living environment, usually inside of a home, operated by people with lived experience, where there are no medical staff in the program. So people bring their own medications. There are not any nurses or prescribers on the teams. And it's really intended to be a place for psychosocial and therapeutic healing. Okay, so emergency departments provide all of these services that we have here on the screen: screening, assessment, medical stabilization, medical clearance, referral and care coordination, boarding or waiting for placement, observation, detox. It is a one-stop shop in many ways to get a number of services. And you have to give credit to those who work in emergency departments, because not only do they have the competencies to do all of these things, but they don't know who the next person is that's coming in the door. And with very little information, they have to make decisions, and they have to be helpful, and then sometimes triage and refer people to the right services, provided that the emergency department isn't able to initiate those. But emergency departments do not provide these services. They don't tend to be known for their de-escalation of psychiatric symptoms or emotional distress. They typically don't have peer support specialists on staff. They don't tend to do behavioral health crisis planning. Warm handoffs are not always the case. They don't tend to do extended observation. That's not what they're designed to do. They may have someone there for a long time, but it's not because they want to, it's because placement hasn't been found. They're typically not designed for behavioral health. They don't offer milieu therapy, so you don't have a support group happening inside of the emergency department. And they're often not recovery oriented. They're much more often led by a medical model that is consistent with what the rest of the hospital system subscribes to. So why change? Why do anything differently than what we're doing it right now? Well, there are many reasons, but one of the big reasons is that no one experiencing a behavioral health crisis should have to experience it in an emergency department. And when we say that, we mean emergency departments are not generally designed for people experiencing this type of crisis. And for all of the reasons that y'all answered on that previous question, those are generally not conducive to a person's well-being or improvements in behavioral health symptoms. I really appreciate Scott. I'm so glad I got a chance to hear him speak this morning. Like I said, I think he's one of the pioneers in emergency psychiatric care, and I'm so pleased to see his model kind of catching fire and being replicated in so many places. And that is not the norm for most emergency departments. I think we would all benefit from having an EmPATH unit in our communities, but many of us don't. And so we have to also think about some of these community-based or community-centered responses that can keep people out of the ER in the first place. Another reason why we have to consider change is something called iatrogenic harm. And this refers to the harm inadvertently caused by the process of treatment. I have had, unfortunately, my own family's experiences with iatrogenic harm. One of my great aunts was hospitalized by her family in the, I believe it was the 1950s. And she had an inappropriate relationship with a doctor while she was a patient at the state psychiatric hospital, and gave birth to a son that she was not able to keep, that they took away from her as soon as it was born. So that would be an example of a place where you would hope, if you're going to an asylum, a state hospital, a psychiatric hospital, that you're getting help and healing, and that it's not making your life more difficult, more traumatizing, just leaving terribly lasting effects when you're really there to heal and to help. So common places where iatrogenic harm has been experienced include emergency departments, psychiatric hospitals, and poorly operated crisis services. We can't, in good faith, say that all of our services are working just how they're supposed to, when you hear time and time again those people with lived experience. Sometimes they refer to themselves as psychiatric survivors. And this goes back 100, 150 years to people like Clifford Beers, who helped to start the mental health hygiene movement, which became what we now know as Mental Health America. You know, we have to remember, we've been treating people poorly in behavioral health for a long time. And if that's the case, then who's to say that we've got it all right now? We have to ask ourselves, is this a healing environment? Is this a helpful environment? So there's some ways that we can recognize and correct iatrogenic harm. I'm not going to get into all of them, but I'm going to offer up two. One is that it requires us to orient ourselves to the care experience of the person in crisis. So when you're designing a crisis stabilization unit or a 23-hour observation unit or a behavioral health urgent care center, you shouldn't have a person with lived experience come to cut the ribbon before you open it. You should have them come to meet with the architects to talk about design and throughput and what's going to make this feel like a welcoming environment. And you should be really keyed in to your client satisfaction surveys. A lot of you do client satisfaction surveys if you run crisis services, and that's great. But I also want you to pay attention to what is the percentage of respondents that you get. Do you only give the surveys to people who are likely to give you a positive response? And does that mean that you give them out not that frequently? Those are some things to think about if you want to correct historic mistakes that lead to iatrogenic harm. And the other is that it requires us to pay attention to the stories that are being told by us and those around us. So it is natural that when we work in crisis services, we're working with people who are oftentimes having the worst day of their life. And we have to be careful that the stories about the worst things that have happened at our crisis programs don't control the narrative of what your crisis program is doing. From time to time, there's sentinel events, there's terrible things that happen. But do we, do we kind of gossip and talk to each other about that worst event, even if it's months or years in the past? Or do we think about how can we be the most helpful to this person? And how do we make sure that the narrative of this of the place that we work is one that is about healing and recovery and improvement, and not one about the worst things that have happened to each of us? So behavioral health urgent care. Behavioral health urgent care is characterized by a set of clinical and care coordination services and supports that are delivered at the right time and in the right time frame. So in that sweet spot, not over-serving people, not missing important treatment professionals or care interventions, but being able to do it just right. I've got a quote here from the Blue Cross MA Foundation. Says it requires the organization of certain behavioral healthcare services and providers who can treat an individual whose condition would likely require emergency services without timely intervention. So we're thinking about how can we meet people in the community? Think about where your urgent care centers are, if they're on the corner of a busy street or if they're, kind of centrally located. We're meeting the people where they're at to get them this service. And we're not thinking of people who need this type of help as inherently dangerous or violent. Studies show that people are more likely, people with a mental illness are more likely to be victims of violence than to be perpetrators of it. So you are bearing a little bit more risk when you start to build a behavioral health urgent care center versus having everybody come to the emergency department. But you do that because of the rewards that it promises for timely access to care and lower negative outcomes long term. So just a little bit about the lingo before we go on. We have all kinds of acronyms in our industry. Isn't it wonderful? I am going to do my best to say behavioral health urgent care, or as we might like to call it, a buck. And I might switch over and I might accidentally call it a psychiatric urgent care, or depending on what state you're in, those are kind of interchangeable. So we'll call that a puck. So if you hear buck or puck, we're talking about the same thing today. Okay, so let's go back to those icons that we showed you about what is included in an emergency department as far as the services that can be offered. So what I've done is I highlighted on the left side the services currently offered in an emergency department, which can also be offered in a behavioral health urgent care center. So those namely are screening, assessment, medication, and referral. Now, the medication one might even have a greater depth of options, because we did a survey of the emergency departments across a state a few years ago, and we learned that less than a quarter of them had access to a psychiatric prescriber, either one that was rounding or one that was assigned to the emergency department. So if you're at an urgent care center, the chances are you're going to have access to a prescriber that will know psychotropic medications better, and then subsequently will have more options for this person. In addition, behavioral health urgent care centers are designed to be able to offer de-escalation, to have peer support as part of the staffing model, and then also to do some crisis planning and say, okay, let's get you set up with some care coordination, or what type of short-term goals do we have to set, and how can we make sure that this intervention gets you to your next appointment, your next meeting with your case manager, and so on. It's also about I've got the areas highlighted that behavioral health urgent care covers, and then it's also designed for behavioral health. It should be recovery oriented, which is why it's helpful to have a peer support there. But you're not going to see milieu therapy necessarily, because it's going to be a short-term intervention. These are usually typically just a couple of hours, and it would be very outside of the norm for somebody to stay for a considerable period of time. So we'll get more now into the details of the model. Behavioral health urgent care is typically unlocked, and it should be located within 30 miles of an urban area or 1 hour of a rural area that you're trying to serve. They're operational anywhere from 12 hours a day, sometimes even 16, sometimes even 24, if you can have the staffing to do so. Now, this is an important one. I'm sure many of you are wondering, well, who would be most appropriate to receive care here? And we would say that it's individuals experiencing a behavioral health crisis, or individuals needing triage, crisis assessment, evaluation, intervention, and discharge planning. Anything that requires like an immediate and extreme response, they may be a better fit for an EmPATH unit, or for a 23-hour observation unit, or if they're going to need more than 1 day, then a crisis stabilization unit should be considered as well. The goal of a behavioral health urgent care is diversion from the emergency department. Excuse me, primarily. It's this idea of siphoning off or taking off a certain percentage of the people who would otherwise be going to the emergency department, or maybe people who are just going to go without their medications until their next doctor's appointment. So it gives them prescriber access. Now, with that in mind, you want to set in some firewalls or some protections, so that you are not simply a medication clinic where people are coming back time and time again when they should actually be seeing a routine prescriber. And they kind of add I don't want to say a wrinkle, but like a benefit to the safety net if a breakdown happens in continuity of care. So let's say you've got someone who went to the psychiatric hospital, they've discharged, the clinician or case manager sets appointments for 7 days and 30 days, or at least leaves a voicemail to do so because it's Friday and the therapist's office or the prescriber isn't answering their calls. Well, what can happen, of course, is that the appointment never gets made. Maybe the person doesn't have a reliable cell phone to check and follow up, or to receive a call to finish off that appointment. And then their medications have run out because the CSU or the psych hospital is only given out a week or two of medications, and prescriber appointments are out, 4 weeks, 3-4 weeks. And so then conceivably this person could come to the behavioral health urgent care to kind of get that bridge of medications covered until their appointment. And then lastly, length of stay. Timeliness is important. Throughput is important. For those of you that know anything about emergency departments, one of the metrics that they get judged on is timeliness of access. How long did it take from the time you walked in the door until you got to a room, or from the time that you sat down until you were seen by a doctor? So ideally, the facility can observe a client for a period of, let's say, 2 to 4 hours. But oftentimes, if there is, for example, no wait, a person may be able to be seen in a very timely manner. So behavioral health urgent care does not include ongoing behavioral health treatment, which would mean like that it's time limited and it's not meant to be a routine ongoing source of care. So back to that example that I used before, you wouldn't want that person coming every 2 weeks or 4 weeks or however often whatever length of time of a prescription a doctor is willing to give. You wouldn't want that person coming right back afterwards. It's meant to cover gaps and to be a complement, not to for these doctors or prescribers to become the outpatient provider of choice for people. So a few different options on the staffing within a behavioral health urgent care. We have seen these operated very, we'll say economically or efficiently, where there's only 2 workers, a prescriber and a clinician, and it's multiple prescribers to cover the 6 or 7 days a week that it's open, but it's not. It can create some challenges if there's a call-in, for example, and you're only used to running one of each of these people during the day. But we've seen it happen. It can be done. In a larger behavioral health urgent care center, you might have a bachelor's level case manager who is doing some of the intake and discharge work. Your social worker or clinician is triaging and completing some type of assessment. And then a peer support specialist who can welcome people, can sit in the lobby. And this is a fundamental difference. I hear countless stories of problematic or challenging individuals who present to the emergency department and they're given a sitter. And the sitter's job is not to talk to them, but just to wait and watch them and make sure they don't hurt themselves until a hospital bed becomes available. A peer support specialist job would almost be the opposite of that. They are encouraged to engage people. They're encouraged to have conversations and to get a sense of what brought the person in there. In some cases, the peer support specialist might even come into the room with the clinician, the prescriber, the nurse, and kind of act as a liaison. How many of us have ever gone to the doctor and forgot one of the important things that we wanted to talk about when we were there? That can happen. There can be there's different reasons why we don't bring things up or we aren't as transparent with some people as we are with others. So peer supports can leverage their own personal experiences to encourage people to open up, but ultimately to find ways to be the most helpful. So some benefits of behavioral health urgent care. The first is that it can be a cost-effective alternative to emergency room utilization for a behavioral health crisis. It provides easy access to a crisis response that does not initially require intensive or secure interventions. I want to draw your attention to just to one area of the crisis, the road. Sorry, not the roadmap. Scott talked about that. The national guidelines for behavioral health crisis care that were published by SAMHSA. It talks about this third part of a three-part process: someone to call, someone to respond, somewhere to go, and that somewhere to go in that document is predicated on being able to accept anyone. And the challenge of that step, if you only have one service in that slot, and it has to accept everybody, then it's only a small percentage of people who are experiencing a behavioral health crisis that are violent or need locked and secure settings. And if that's the case, then you're going to send everyone into that setting, and you're going to put people through doors that are locked when they don't need to be behind locked doors. So this kind of highlights a benefit of a right size treatment approach instead of an any size treatment approach, is that a behavioral health urgent care center is not for everyone. It's not for people who are extremely violent. It may not be a place where you can have a police drop off if that's kind of what they're expecting. However, it can serve an important purpose, and it can complement some of those other services within the continuum. And then lastly, following hospitalization or a CSU visit, behavioral health urgent care can be a valuable safety net if there's a breakdown in continuity of care. Without behavioral health urgent care, what you might see happen is that a person who discharges from a CSU then might return to that CSU and meet criteria and be admitted, or they might readmit to the psych hospital when in fact all they needed was to see a prescriber or to see a nurse. And that's something that can be handled in a matter of hours for a much lower cost than a full stay, a second stay in the psych hospital and in the CSU. The psych hospitals and CSUs will also appreciate this too, especially if they are measured on readmission rates. So by bridging that gap, these bucks can keep people out of those levels of care after they've already been in them. So a couple steps here to think about in an ideal crisis system, and then we'll open it up for questions here pretty soon. The first is geographic access. You want to make sure that a lot of people can see this. When I was making a recommendation a few years ago about building a behavioral health urgent care center in a community, one of the people who lived in the rural areas spoke up, raised her hand, and said, "Well, why can't we have this here? Why can't we have this in this small town?" And it really turns out to a matter of volume and utilization. It has to be a good investment, which means it has to be used a certain number of times that it can kind of pay for itself. There also needs to be availability. If you only have, let's say, one chair or one room, and you get 6, 10, 15 people a day, they may have some overlap and there may be a long wait. And so that also kind of speaks to the capacity that they can serve the number of people that would be needed. One way that you can do that is you can go to your local emergency departments and ask them for data of how many people do they serve in a year, and then what percentage or what number of those people are identified with a behavioral health disorder or reason for presentation. And then you could ask yourself, okay, well, what if half those people came to a behavioral health urgent care center? How many people per month is that? Break it down to how many people per week, and then you can staff accordingly. An ideal crisis system might also have a place to do a medication evaluation. It can withstand the volume that we mentioned, and there's enough of them around that it serves a high percentage of your population. Perhaps never 100%, but it gives, if I'm in, I don't know, if I'm in Chillicothe or St. Clairsville and I am a long ways away from a psychiatric hospital, let's say 2-3 hours, if I'm only 30 minutes or an hour away from a behavioral health urgent care center, they might still be able to help me, and it's cut my wait time in half. So let's talk about funding a little bit. One way that you can fund these centers is as a bundled rate, and it could include the cost of the prescriber, the nurse, the clinical, the peer support intervention. And then because you'd expect people to not stay for that long, all of the interventions should probably be happening in the first 2 or 3 hours that someone is there. And it'd be much more rare for them to stay longer than that than it would in a 23-hour observation unit. So you could bundle all those up and say, okay, this is what the rate's going to be per day. You could use existing per diem codes for crisis intervention or for a medication review. But it's also important to explore a diverse payer mix. So is this something that you could use those Medicaid codes for? Could it be levy funded? So for the ATOM boards that have the safety net responsibility, if you're already funding a crisis call center and a mobile crisis team, does it make sense to also fund a behavioral health urgent care center? What would that look like? And what would the cost savings be? And then these are services that on the medical side, commercial health plans are very familiar with. Excuse me. So if you can build your model to have some similarities to the medical model approach, then you may be able to do some negotiation and at least start with a pilot so that you can serve people of different payer types. I think it's also important as you're looking at funding, you're going to save the community money when you do this. Fewer CSU visits, fewer psych hospitalization visits, and fewer emergency department visits. When you do that, if the system is not already set up for you to actualize those savings back into program operations, and think of what the Medicaid health plans pay for, and then what the mental health and recovery boards or ATOM-H boards pay for. If they don't pay for psych inpatient, or if they don't pay for emergency department, then whoever does, you're saving them money. So it's important that you can demonstrate and that you can track good data early on to know how much does it cost for a person to go into one of these other services that we don't want them to go into if they don't have to, and how much do we save that payer every time? And how can we have a conversation with them to not ask for all of the money that they save, but what about a quarter of it? If you saved a health plan $1 million in a year, would they be willing to give you $250,000 for ongoing program sustainability, so you can continue to offer this benefit in your community? All right, let's get the phones out again. What barriers would exist in your community when trying to send someone somewhere else than the emergency department? So if you wanted to build a behavioral health urgent care or a 23-hour observation unit, what barriers would exist when you're trying to make a change? Okay, so the biggest one coming up so far is transportation. We also see funding. The ER is territorial about patients. Okay, so ERs might complain about having behavioral health patients in their emergency department, and they might also know that it makes them money because they still get paid every time that person comes. Seeing some really good responses come in. Lack of behavioral health physicians. One thing I didn't mention in the staffing model, this is very conducive and open to some type of telehealth option. So maybe you have a prescriber in person 8 hours a day, and then the other 16, or if you're not open 24/7, then kind of on more of those off hours, you would have an on-call telehealth person who could see patients as they're coming in. Something else to keep in mind about I'll come back to that later. Police officers' willingness to drive elsewhere. Yes, a lot of communities in Ohio are relying on police to transport across multiple counties. Would they be willing to make a change? there's one that I don't really see in here. At least I don't think. I'm trying to read this as fast as I can. Is EmTALA. EmTALA, as Scott talked about, you can't leave the emergency department without a place to go, according to EmTALA, and that's a responsibility of the emergency department. If you have a psychiatric emergency, you can't leave until you have a bed to go to, short of an AMA discharge. So that might be a challenge as well. And the willingness to get treatment. Okay, so people might not understand where you're taking them, and are they going to trust it? These are good. Thank you so much. These are great. We should make a whole presentation about barriers. Good. Thank you for submitting those. All right. So the future of behavioral health urgent care, it should include standards. So we should have some agreed upon clinical standards and operational standards for how these work. In other states, we see these come at the direction of the state behavioral health department or Department of Health and Human Services. We need common language, so we all are talking the same the same dialect, if you will, and know what a service means, and what can you bill for, what can't you bill for. We also need good metrics and key performance indicators. What would be the indicators that an urgent care for behavioral health is working well? Well, I'd want to know diversion. I'd want to know readmission rates, or maybe we'd call it representation, because you're not necessarily admitting to an urgent care center. Client satisfaction, for sure. Timeliness. Are you not just throughput, but the number of people you're seeing every day? Is it worthwhile? And this last one's very important, which is compassionate and committed professionals. A behavioral health urgent care isn't going to work if you just take people from the ER and stick them into an urgent care center, especially if they have no interest, frankly, in the population. You need a team of professionals who understand recovery as SAMHSA defines it, who are not too focused on hierarchical structures and say, the doctor is up here and then everybody else is down here, and then the peer support's off the screen. Okay, people need to have a shared understanding of that this is going to be helpful, and you can bring skeptics to the table, but they have to become believers and supporters. And if you have people that just continue to talk about why this isn't working, well, you can make a whole list of why the status quo isn't working. So you need people who are committed to the ongoing success of the program. So, you may be having your own sign in your community soon that instead of welcome to the accent room says welcome to the behavioral health urgent care center, the BUC, the PUC, whatever you want to call it. And I hope that you do. I hope that these some of these concepts start a conversation in your community, so you can think about how to provide this timely access. And I know that the next couple presentations here this afternoon are also going to give you some concrete examples of what's happening in communities in Ohio that have been experimenting with this. Just two more things. One is I want to show you, I just want to let you know that I'm very impressed with how the state of Ohio and Ohio MAS is dedicating resources to crisis services. If you haven't checked it out, check out the crisis services dashboard. It kind of shows you where all of the crisis services are in Ohio. I drool over this kind of thing. It is so cool. I wish every state had this level of interactive and just outcomes focused work with services. And then check out the crisis services compendium. A great resource that has some really good definitions and explanations of services. I've got an additional resources page that I drew some of my, that includes some of my sources or some of my inspiration. If you would like that, just send me an email. I'm also on social media. You can follow me or TBD Solutions on Twitter. And with that, I'm happy to take questions or reflections.
Thanks, Travis. Such a good presentation on kind of the role psychiatric urgent cares can play. We have several questions in the chat, and I think I'll start with, let's see who asked this first. Are crisis receiving centers that are fusion like RI International seem to be very much in line with this, with the exception they are not hospital-based. Am I incorrect in making this comparison?
I think both the RI models and what I'm talking about are typically predicated on not being hospital-based. And that's, it's kind of the, I don't know if promise is the right word, but it's kind of the concept of community mental health, is to be in the community. And when you start building all of these on the same campus, I think you're more likely to hospitalize people. You're more likely to send somebody to the ER that a more community-based program would just tolerate a little bit more risk, or not be so quick to jump to that higher level of care. So yes, they would all the examples we're talking about would be community-based and not connected to a hospital.
Great, thank you. So there's kind of two questions here that you might be able to get some insight to. So I'll just read all of them, and if you're able to answer them.
Okay.
In the physical health world, there is a separate MCO coverage for urgent care. Is Ohio considering adding an urgent care service under ODM? Also, is ODM considering adding reimbursement for peer support outside of AOD and Ohio RISE services? The reimbursement models are often drive what is available in the community.
The first question I don't know the answer to. Reimbursement of peer support, I also don't know the answer to. So at the risk of wasting 2 minutes saying only to get to I don't know, I think those are good questions that perhaps other people on this call might be able to answer.
Yeah, thank you. This might be the the last question we'll be able to get to, but someone is curious about measurement. So could you please let me know if there are any known BHUC measurement frameworks, outcomes, metrics available?
We have helped design a metrics portfolio or framework for some behavioral health urgent care centers. There's a publication that just came out from NASHBID recently. I think it was in the last maybe couple of months, about metrics and crisis services. That's worth checking out. I always recommend Margie Balfour's crises paper that came out maybe 4 years ago now. I think that's also really good.
Great, thank you. And because we have some more presenters, I think there's 2 questions in the chat. I don't know if you're able to go and answer those.
Yeah, I'll answer them while the next session's starting.
Thank you, I appreciate that. And I'll ask Molly to come on and let us know who's up next.
Yes, thank you again, Travis. I'll definitely be thinking about your presentation as I'm in the drive-thru at Wendy's ordering a chocolate frosty. So next we have a panel presentation from a behavioral health urgent care in Licking County. We have Kate St. James, who is the president and CEO of Behavioral Health Partners of Central Ohio, and Kay Spergel, the executive director of the Mental Health and Recovery Board of Knox in Licking County.
Thank you so much, Molly. And I just a quick clarification. These are urgent cares that are both in Licking and in Knox counties. So we're covering 2 counties here.
My apologies.
No worries, no worries. So I'm going to go ahead and start for us. And the first thing I want to do is actually get the slide up. So give me just a moment here. Okay. Molly, is that coming through?
Yes, it is.
Yeah. Okay, perfect. So one of the first things that I would really love to do is talk a little bit about my organization, just to give some context for it. Unfortunately, there we go. I was going to say it's not going forward for me. There we go. Okay, so just a little bit on my organization for some context here. So Behavioral Healthcare Partners, we, as I said, we primarily serve both Licking and Knox counties. We are a nonprofit community behavioral health center. We provide outpatient and residential services for mental health and addictions. We serve nearly 6,000 individuals every year, and that is pre-urgent care, and that will become important here in just a moment. We're also the certified crisis provider for both Licking and Knox counties, and that includes mobile crisis. And we have, over the last year, opened 2 behavioral health urgent cares. The first we opened in Newark a little over a year ago, actually in November of 2021. And our second we opened in Mount Vernon, which is in Knox County. And we opened that up in February of this year. So speaking of the urgent cares, I think what might be really, really helpful is for folks to see some of the metrics. I mean, Travis was talking about that there at the end, you know, like what sort of metrics are there to help understand the outcomes of your behavioral health urgent care. Since we have a full year of data, we are happy to present some of this information today. So what I can tell you is over the past year, we have served over 1,600 individuals through our behavioral health urgent care. Just a little over 1,400 was adults and just under 200 children. Our urgent cares, they serve individuals 12 and up, although we have been known to see children who are younger, and it just really depends on what the circumstance is. 60% of the people who come through are coming in for a psychiatric service. Generally, what we're talking about here is some sort of bridge medications for individuals to get them through to a next appointment or until they can get into a provider. The other 40% is really comprised of individuals coming in for counseling or some sort of other sort of resource. Now, this 95% number is actually a little low. What we have found is between 98 and 99% of the individuals who are coming in through our urgent care are being diverted from higher levels of care. So the emergency departments, hospitalizations, or even our own crisis teams. So people are getting diverted away from these higher level, more stressful levels of care. The top diagnoses that we have seen over the past year: major depressive disorder, generalized anxiety disorder, and PTSD. And, you know, when we started to think about developing an urgent care, we really made an assumption that the majority of the people who would probably utilize it would be individuals who were already known to our system or even our own clients. What we found out in the beginning, though, was that 60% of the people who were coming in were actually accessing services in the behavioral health system for the very first time. So they had never had a behavioral health service up until this point. And looking back on that, I'm not so sure why we were so shocked by this number, particularly since, you know, what the data that we have from a national level says is that, you know, pre-pandemic, normally what we would see is about 20% of individuals who were experiencing mental health disorders or issues or symptoms would seek out treatment. But since the pandemic, that number has doubled up to 40%. So there's a lot of people out there who want to get help, but maybe just don't know where to go to get it. So I wanted to share this information because I think it helps as we start to get in and talk about our actual urgent care, that this is pretty significant. So why did we decide to open an urgent care? And I think you know, for the most of you, this probably is like, yeah, well, that makes perfect sense. And it really was very simple for us. I mean, it was our intention was to help individuals in distress get some sort of relief. And in particular with our urgent cares, what we were trying to do was to help prevent something escalating into a crisis. And as we all know, if you can help mitigate the crisis, then you're going to see less hospitalizations, less utilization of crisis services. And that was really the intent for us in developing our urgent cares. So let me tell you a little bit about what we came up with. And, you know, we started this process at this point. I mean, it's getting close to about 4 years ago when we started to talk about this internally. And at that time, we were trying to decide exactly what was needed in the community. You know, we as an organization, we're community behavioral health. So we're constantly thinking about what are the gaps, what are the things that we need to do to make sure that our community is safe and cared for. And, you know, listening to our partners, listening to the community at large, listening to clients, but certainly, you know, Kay and her staff over the Mental Health and Recovery Board just have their fingers on the pulse of everything that's going on. So, you know, having conversations with them, we realized this was something that was really needed in our community. So we started to do the research, and at that time, there really wasn't a specific national model there. And I don't think there's, Travis did a lovely job of presenting it, but as you'll see, our urgent cares are just a little bit different than what he was presenting. And so there really wasn't a model that was really kind of fitting or getting at the type of service that we wanted to deliver. So what we were seeing was that most of the models were really crisis-based. And then oftentimes it was an organization's crisis response team, or it was a health systems response. And this just didn't feel like something that we needed because we already had a crisis response team, and they are embedded in our local hospitals and they're out in the community, and we have this mobile response as well. So we started to really think about, well, if somebody was going to come through an urgent care for a behavioral health issue, what would they want that to look like? If it was us going through or our loved ones who needed this level of care, what would we want that to look like? And what we kept coming back to was really the concept that is very similar to physical health urgent care, right? You all know what that is. I mean, most people, most adults have at some point in their life had some sort of an experience in an urgent care. So we started to develop what we thought was going to work really well for our community. And I'll show you this. I'm not going to go through, oops, went backwards there. Hold on a second, sorry. I'm not going to go through all of this, but this is what we proposed, right? So there's a lot of stuff on this page, very complicated. There's a lot of entry points and pieces and parts that are moving around. So this is what, you know, we started off with, and this is where we are today. So what we ended up was, you know, this has got to be simple for people. They need to be able to know that we're there, and they need to be able to walk in and get the services that they need. So we have, you know, we have this open clinic. Folks can come in. They meet with, we have a certified medical assistant who runs our front desk in our lobby, and they are phenomenal because they can do the screenings, they can take the vitals, they can do the demographics. They can also, if they have concern that maybe what we're looking at is more of a health issue, they can direct the individual and help them get to the urgent care for our health system, which is right around the corner. Once they've done that triage and they've determined really what the presenting problem is, what the issues are, then they can direct them to whoever the service provider is that would be appropriate for that service. So we have nurse practitioners who, as I said, can provide that bridge medication, or help an individual get linked into ongoing services. Just a quick background story, and we get lots of these stories coming through our urgent care in the past year. We had an individual who had moved from out of state here, had just lost their spouse, was experiencing a lot of grief and depression, and had medication, but was about to run out. And unfortunately, because they were out of state, their doctor in the other state was not comfortable doing another prescription. So they were able to come in. We were able to get them that bridge medication and get them linked up with an ongoing provider. And that just felt very world-changing for that individual. We have counselors who are trained in brief solution-focused interventions. They are also trained in crisis interventions, and they are public health officers. So they can do the whole crisis continuum for somebody coming in. And their response is really about, again, providing some sort of brief intervention with the individual to help give them some sort of relief. And then we do work very closely with our peer organization in both communities to have that peer component in our urgent cares and have that available if an individual could really benefit from having a peer either present or work with them. And then we discharge. And this is generally done by the last person who is working with the individual, so that, we're not continually passing people off and on. And our discharge is, again, very similar to physical health urgent care. We are, giving them a sheet of paper that they can walk away with. What did we see you for today? What were the sort of things that we talked about? What are the recommendations that we've given you to walk away so that when you go home, you can continue to feel better? And what were the recommendations that we made in terms of referrals or those sort of things? The last thing I'll say is that then we do follow up with individuals afterwards, usually a couple of days to a week after, because we want to make sure that folks are getting everything that they needed, that they are linked into services, because we just don't want somebody to fall between the cracks. So, of course, one of the questions that's always on everybody's mind is, all right, this is great, but how do you sustain it? And particularly, how do you sustain it financially? So we were very fortunate, BHP was fortunate to receive one of the SAMHSA Certified Community Behavioral Health Clinic expansion grants. And this helped immensely with us opening our 2 urgent cares. But from the absolute beginning, we were really clear that we wanted to build in sustainability from the beginning. And I think we've done a really good job of that in terms of, the type of things that Travis was talking about, right? So we were able to bill for Medicaid, for commercial insurance. And then we certainly have the support, and we greatly appreciate the support that we get from the Mental Health and Recovery Board as well. Another thing that we did, which I will pat ourselves on the back because I thought this was very smart, we made sure that every office in our urgent care had a telehealth unit. We do this with all of our outpatient and our residential programs as well. But the beauty about this was, because we have 2 urgent cares, if one of the locations is getting completely slammed and the other is maybe a little bit slower, there is the possibility for the one location to help out with the other. This is also wonderful in terms of when you have people who are going on vacation or they're out sick, because we do let our people out to see the light of day every once in a while. But that's a very helpful thing that helps with the funding as well, because we don't have to restrict hours or close down because of staffing issues. The other piece of this is that our psychiatric department and our outpatient counseling department also can jump in and help out if the urgent cares are experiencing a very, very high volume. So I'm going to stop there for a second and turn it over to Kay.
Well, good afternoon, everybody. First, I want to say on behalf of the MHR board how proud we are of BHP's efforts in terms of creating and implementing this really very, very important service to both of our counties. It has been really very critical for our growth and development. As I think about the impact of the urgent cares on Licking and Knox County, two words come to mind immediately. One is it has really instilled a sense of hope for people, and two, a sense of relief. Now, I will be the first to admit, and I think Kate would agree with me, that this is not going to solve all of our issues. But I will tell you, if we talk to our partners, be they in the criminal justice system, law enforcement, the schools, the rest of healthcare, social services, the homeless housing crew, they will tell you that this has just been a real game changer for them, because it does provide a much quicker and much less stigmatizing way of being able for people to gain access to the care that they need. And one of the really cool things, and Kate hasn't, I think, Kate, you talked about the name of the clinic. The clinics are called Care Now clinics. And what BHP tried very hard to do when they crafted these programs was to try to make them as normalizing as possible and to really address this whole issue of stigma or reasons why people choose not to engage in our services. And so as they advertise this, and this service is really advertised as a universal community service. I want people to know this. And so we really understand that being part of the public behavioral health system, we do have priority populations we work with, but we wanted the general public, BHP wanted the general public to feel very comfortable in coming to their doors to use these services. And so the laundry list of things they tell the community they can help with is if you have extreme sadness, if you're excessively worrying about things, if you have changes in sleeping patterns or loss of interest, low energy, mood swings, so on and so forth, or grief. They really use some words that people can begin to get themselves around, that they don't feel so fearful about coming forward, because we all know that for a number of people, how difficult it is for them to admit they have any type of emotional disturbance at all. So BHP works really, really hard to try to provide the most comforting environment and approach they possibly can to ensure that the public feels okay about using their services. So if I would leave you with anything, I think it is that we are two rural counties, and we recognize that most of our services take place in our county seats. One of the hopes that we have in the future with this approach is not only to offer these services in Mount Vernon and Knox County or in Newark and Licking County, but also to think about some of our other communities that are further out in the country, in our rural communities. And I know BHP is thinking about one in the western Licking County. They're thinking about another one in Knox County. And again, these would be developed with the community in mind as to what needs to be done in order to have people feel comfortable in using the service. And Kate, I don't know if you want to offer anything else other than that.
No, I think you really hit on it, Kay. And what you started to allude to that I'll just finish up is that it's so important to really think about what is needed in your particular community, because as I'm presenting this model, what is working for us may not work in another county. It may not work in an urban center. And so, you know, I want people to be really mindful of that.
And I think the same thing will be true with when we or BHP looks to expand them. How that model plays out in other parts of a rural community may be different than in a more suburban, small city area in a county seat. And so part of it is figuring out how to adjust that to the needs of the people, the community that you are serving. I think that's very well stated, Kate. Excellent. This works for us, which we're very excited about.
Kay, anything else from you?
No, thank you.
Okay. Thank you, Kay. So, as everybody does when you start a new program, you start to think about, okay, what were our lessons learned? And of course, There were, great opportunities that have come out of this and continue to come out of this, as well as challenges. So in terms of opportunities, I mean, BHP has always had the luxury of really great relationships in our communities. But what we found was really interesting. We had other partnerships pop up like we wouldn't have expected. So for instance, in Knox County, the fire department got really, really excited about this and on board with us. And even though we may have, our paths may have passed here or there, they were just very, very appreciative of this and have been very much champions and supporters of our urgent care. The other thing is, as this is becoming an emerging thing in our system, I mean, if there's only 77 of these nationally, and I have 2 of that number, right, that there's some real opportunities to create some evidence-based practices, some evidence-based models around this. We've already started to have some conversations with universities because I think there's a real opportunity here. The other thing that I think is really interesting is that, BHP, we provide internships, preceptorships, practicums, those sort of things. What we're hearing from the colleges close to us is that students are starting to ask if they can intern in our urgent cares. So this is something that I think people are really starting to see the need and the benefit, and that I'm really heartened that emerging behavioral health professionals are really excited about it as well. And of course, a couple of people have talked about this today. There's an opportunity for cost savings, right? So, if I'm diverting 95 to 98% of the people who come through our urgent cares away from a higher level, a more costly level of care, then there's an opportunity to do some cost savings. We've had a couple of conversations already with some of the managed care organizations, and I would encourage anybody who is doing this or thinking about doing this to have the same conversation with them as well. In terms of challenges, and I'm not going to spend a lot of time on workforce and funding because everybody knows that, right? I mean, we don't have right now a payment structure for urgent care level of services in the state. So we have to think about what are those creative ways of funding these type of services. And it certainly is a braided sort of situation in order to make them substantial and financially viable. The other thing that I will mention that our chief clinical officer brought up to me the other day is that, the pace of this work is very intense and can be very fast. And so you're going to need people who have a special skill set and a special interest like that. But even if that is their thing and they're really into that, there is still a lot of intensity that goes along with it. And what we're trying to do is now find that balance of building in some of that self-care for the people who do the work so that they don't get burnt out and that they can continue to be there for the community. So as Walt Disney says, the way to get started is to quit talking and begin doing. So we're going to quit talking right now and see if there are any questions. And thank you so much for having us here. We greatly appreciate the opportunity to talk about our programs. And I put our information up. I would certainly encourage you to reach out to either Kay or myself. I can talk about this all day long, and I have in the past. But please feel free to reach out and ask us any questions. Happy to be there.
Thank you. Thank you both for talking about, your experience with, starting in urgent care and, all the work that's you've put in it for your counties. We'll be sure to include your contact information in your slides when we send them out to the participants here. We have one question so far in the chat. We invite other questions. We do have some time, but this first question is: are appointments scheduled or is access on a walk-in basis?
It is purely walk-in. We do not schedule appointments. The other thing that I will say is that we don't turn anybody away because of their ability to pay, or if they don't have a funding source, or if they're underinsured. And our hours are a little different than what I saw in some of the other models that Travis presented. We are open Monday through Friday, 8:30 to 4:30. What we have found in talking with other colleagues around the nation is that in general, if you have later evening hours or weekend hours, people really just don't access them. And the fact that we have a 24/7, 365-day crisis team, for us, we didn't feel the need to have those longer hours.
Great, thank you. I think that relates back to your comment, like, you have to figure out what works for your community.
Absolutely.
Having more access may work other places, but you found that, those set hours, people weren't accessing it after that time. We have a few more questions that came in. Do you have a policy for law enforcement EMS drop-offs? Any no wrong door policy?
That is a good question that I can't answer right now. But I would be happy if we can, if I can, in the next segment, I can reach out to our folks and answer that question for you.
Great, thank you. Another question was, how many staff are available?
So in each urgent care, we've got approximately 4 staff. But then again, when you talk about that cross coverage between the two, then you're talking about 8 staff that are available. But then once you back that out even another layer to our psychiatric department and our outpatient counselors, who, if they don't have an appointment, if they've had a cancellation or no-show and they can hop in, that just opens it up widely. But in terms of each location, it's generally about 4 people at a time.
Thank you. Another question. If no one is turned away, how are meds paid for? Are you billing third-party insurance as well as central pharmacy?
Yes.
I thought that was going to be a more complicated answer. I don't know. I don't know why. The yes just totally threw me off.
Elijah, I can get more complicated if you want, but
no, that's good. You answered the question. I just wasn't.
They did such a great job of asking the question. The answer came very quickly.
We do have time for 1 or 2 more questions if anyone has any other ones.
Oh, I do have a question. I do have an answer around the policy. We do not have a policy.
Okay. Thank
Fortunately, you. The person who can answer that is in this seminar. She just texted me. She should have been talking instead of me.
How does your team respond when someone presents at close of business?
So what we do is we say that we close at 4:30, but we actually close at 5. So what we do is we close the doors at 4:30, and that way that gives us a chance to work with the people who have come in, but not overtax our staff and make them stay up until, because, and that's one of the things that I will tell everybody is that if you haven't started this yet and you are going to start it, be prepared for there to be a lot of change, right? As you get in and you start to work through things, you'll realize that some things won't work. Move on, try something else, right? So what we were finding in the beginning is people were coming in right at closing time, and that was making staff stay even later. So what we've done is we've publicized that we actually close a half hour earlier than we actually did.
Oh, well, good thinking on your part. Thank you. And that is all the time we have for questions and answers. Again, thank you both for this presentation.
Thank you so much.
I'll turn it back over to Molly to introduce our next speakers.
Yes, thank you, Kate and Kay again. It was so important to hear about the community impact that's producing, real results in real time. So last week, without further ado, we have another panel presentation from a behavioral health urgent care in Lucas County In this panel presentation, we will have Scott Silak, the Executive Director of the Mental Health and Recovery Services Board of Lucas County, and Courtney Burrow, the Clinical Director for Crisis Care at the Zeff Center. And Scott, I have your slides pulled up if you'd like me to share my screen.
Sure, go ahead, anytime.
All right. All right, can everybody see that?
Yeah, thank you.
Awesome.
Well, welcome everybody, and I'm gonna keep my comments brief because Ms. Burrows is the star of our panel. I was asked to describe a little bit about our process and how we came to the conclusion that we wanted a behavioral health urgent care in our community. We started our discussions and processes back in 2013, 2014, if that gives you some ideas, with an expected goal, next slide, please, to provide an intermediate or immediate assessment and intervention for people experiencing moderate to severe symptoms, dysfunction, or risk. What we identified through a lot of our local data, community health assessment, we did a 700. We did a heroin and opiate survey where we had 700 responses. We did an internal research study on people being exited from the jail, and we found that 26% of the adults rated their mental health as not good for 4 or more days during the month, and that was out of our community health assessment. We also knew that about 18% of 9th through 12th graders had seriously considered suicide, not seriously completed suicide. I apologize for that typo. And 56% of the respondents, over 700 responses again, to our heroin and opiate survey in 2013 said they didn't know where to go to get help. And then we know that we have about 60 inmates at the time, about 60 inmates being released per day. And our data showed that about 57% of them were involved in our system at some point and would need further assessment, medication access, access to prescriber, and linkage services. That information culminated into our strategic planning process, which identified a need to do further gaps analysis. Our gaps analysis, if anybody's been around long enough, if you remember that SAMHSA's good and modern system was the bedrock of what we decided to look at the time. That group, or that modeling, was done by a access to treatment work group, which had over 65 members participating throughout about an 8-month process. Those individuals identified that they felt that the way we were currently accessing our system through what we called a central access point, everybody went to one place, got an assessment, and then they were distributed to our system, was no longer working as designed, and they were recommending a no wrong door policy. The committee also identified that there was significant need to improve routine and urgent access to psychiatric services in particular. So if we could look at the next slide, and I know I'm going pretty fast, but I just want to give you an overview of how we got to where we were. The recommendations coming out of that committee were to create 2 items, a recovery helpline and an urgent care service. And these 2 items would be paired together to help identify routine as a response, not the only response, to improving routine and urgent access. At the time, and if you were at the time, if you were listening to some of the other speakers there, we had this grand vision for what our urgent care might look like. We had actually assigned those services to our current service provider, crisis provider. We thought that it would be great if they would be open from 8 a.m. to midnight, 7 days per week. We were very clear on the services that we wanted. We wanted immediate access to assessment, medication, brief treatment, and linkages for new and existing clients. And that included both alcohol and drug and mental health disorders. We had developed, along with community partners and the Wood County Board and the Hancock County Board, a recovery helpline software that helped support referrals and linkages. And we wanted to use that as a bedrock for how we would make referral services back into our community and then track the data associated with those linkages. And then, of course, we connected it into our crisis provider because in case they were in need of, individuals were in need of emergency services or if hospitalization was required, there would be that immediacy of availability. Just a little bit about cost before I turn it over to Ms. Borough is that our initial cost back in January of 16, when we first started, it was first 6 months, were about $350,000 for the helpline and about $525,000 for the urgent care center. Currently, the budget, while we don't track numbers like splitting them out like we did initially, combined adult CSU 23 observation and urgent care at Zeff Center is running at about $2.5 million as budgeted. That isn't actual. Well, what we know is that there is a population that benefits critically from having access to the immediacy of care. We have other community mental health centers making referrals. We have courts making referrals and jails making referrals. And we also have our PATH team, our mobile PATH team that is very fond of using the urgent care model as well. So with that last statement, we're very proud of the work that we've done. We are very excited to be on this new journey of urgent care with Zeff Center. And I will turn it over to Courtney Burrows for a presentation about what Zeff's doing.
Thanks, Scott. Molly, I think you have my presentation. Unless you want me to pull it up, it doesn't matter.
Yep, I got it right here. Can you see it?
Thanks. Yep.
Yeah.
So my name is Courtney Burrow, and I am the Clinical Director of Crisis Services at the Zeff Center. I'm going to give kind of a more in-depth about our psychiatric urgent care. If you want to go to the next slide, Molly. First, I can tell you a little bit about some of the things that we do at Zeff for crisis care. So we do have a 24/7 call center and also a 24/7 mobile response team. We operate a mobile response and stabilization service, or an MRSS team, a 23-hour observation area, the adult crisis stabilization unit. We have a behavioral health deflection center or area, and then psychiatric urgent care is our latest service line that we've opened. In the future, we'll also be taking on youth crisis stabilization unit and expanding our psychiatric urgent care to cover younger youth as well. Right now, we see 13 and up in our current psychiatric urgent care. You can go to the next slide, Molly. So I'm going to talk a little bit through the process, but first I want to talk about an individual that we served, just to give you guys an idea of some of the things that we see. We had a male come in who was referred to us actually from an emergency room. He had gone there, recent separation, a lot of depression, no history of any psychiatric medications. He had called his primary care and they did not feel comfortable prescribing psychiatric medications. So he was referred to us for psychiatric urgent care. He did admit to some vague and fleeting suicidal ideation when we saw him. We were able to get him prescriptions that day for him to start medications. And then our emergency services team did safety checks with him for a couple days. He actually had done a satisfaction survey written back into us and said that the service itself really, he wouldn't be here without it. And it wasn't just the medications, it's that he was treated kindly in a non-judgmental way. His experience with the emergency room was that they felt like they wanted to admit him to the hospital, and he had a full-time job that he didn't want to lose. And he was feeling like there just wasn't any help for him. So this particular service was perfect for him, and it really did make a huge difference. So our process is when people arrive, they meet with our peer support staff to get registered, do all of those things, sign all the papers, and then they meet with a clinician. So we have an independently licensed clinician that works in our psychiatric urgent care. She does an assessment and then figures out where people want to follow up. Like Scott said, we have access to recovery helpline. So we have the ability to schedule intake appointments anywhere that somebody wants. And that may be that they've historically gone to one of those agencies, or geographically it makes sense for them to go to those places. And we're able to get them those immediate appointments. If they are already linked somewhere and they just need a follow-up appointment with their already existing agency, we're able to do that too. And then they sign the releases of information. So then they meet with our prescriber, and our prescriber, we use a psychiatrist and a physician's assistant. So they meet with the prescriber and do their evaluation, and then we can call those meds into whatever pharmacy they want. We can give them prescriptions in hand if they prefer that, or we can utilize central pharmacy for people that don't have insurance as well. If people don't have insurance and we use central pharmacy, we have to do a shorter term 10-day script instead of maybe 15 days or 30 days, depending on what the person might need at that time. You can go to the next slide. So one of the things when we started urgent care was trying to figure out that if the person we were seeing was in the right place, and then what kinds of services might they benefit from outside of urgent care. So we want urgent care to be a bridge to another treatment center. And so what we use is the GAIN, Global Appraisal of Individual Needs. And our clinician finishes that with the patient to answer the 20 questions. And it gives us an idea if that person may need substance use treatment, if they might benefit from therapy, case management, and then we can make all those referrals right from urgent care. So our little flyers on here, and I don't know how easy it is for people to see, but our hours are 10 a.m. to 6 p.m. Monday, Tuesday, and Friday. Wednesdays and Thursdays, we do noon to 8 to offer some later hours. And then on Saturdays, we do 10 to 3. Most of the referrals that we get on Saturdays are from emergency rooms and local hospitals. We get some later referrals during the week from the jails or courts and from other local agencies that are closing at 4:30. If they're getting frantic calls at 4 p.m. from people, we get some of those referrals as well. You can go ahead, Molly. So the biggest part of psychiatric urgent care for us has been the care coordination part. It's making sure that somebody has that follow-up appointment scheduled, doing the referral, and then kind of following up a little bit to help and make sure that they remember that appointment, have a way to get to that appointment, that sometimes we call the day before and say, don't forget your appointments tomorrow. And then one thing that we do after we have people sign that release of information, we fax everything to their agency of choice, but we follow up with the agency afterwards and say, hey, was so-and-so able to make their appointment? Some of the people that we see in psychiatric urgent care, while they might not be actively in crisis, they really do have needs follow-up needs. And so if they weren't able to make that follow-up appointment, we want to make sure that we're doing our due diligence to make sure that they're taken care of. So some of the types of patients that we see really are people who haven't been on medications before, like the example I shared, or people who've been off medications for a long time but want to get back on them. People who are receiving medications from their primary care, but their primary care isn't comfortable continuing those medications, so they need to get into psychiatry. And sometimes people who have an appointment scheduled, they have gone on their own and scheduled an appointment with a psychiatrist somewhere, but those appointments are scheduled so far out that they just really need something a little bit more immediate. And so if a person has a prescriber already, we do still see them in psychiatric urgent care, but we really work with that prescriber. We call with the person that we're seeing and see if we can get them in any sooner, or if they're willing to do walk-ins. Some of our local agencies are willing to take people on a walk-in basis if they're an existing patient with them. So we do a lot of that kind of work in the beginning. So some of the people that come in for psychiatric urgent care don't even see the prescriber here. They work with the clinician and actually get all that stuff figured out without ever having to see the prescriber. You can go ahead, Molly. And then I know we've been talking a little bit today about data and tracking. So this is just some of the information that we track for our psychiatric urgent care. So we track total enrollments, but also, like I said, not everybody sees the prescriber. So we track people that were enrolled versus people that were actually seen by the prescriber. We track readmissions. So anybody that is seen again a second time is considered a readmission. The average time from the time a person checks in until they get discharged. And then we include all the way through it. From the time you get here, how long is it until you see the clinician? From the time you get here, how long is it until you see the prescriber? And then how long is it until you're finished with your visit? We track all demographics, internal and external referrals. So Zeph Center itself is an outpatient clinic. So some of the referrals get referred back to us, and then we also refer externally. And then the average number of days to somebody's follow-up appointment, and the agency of choice that we refer people to. So just some of the numbers that I know, and this graphic is actually from a few days ago, maybe last week, so it's not completely up to date, but we use Power BI dashboards to track a lot of our data, so that's what this graphic came from. I know that as of today, we had 167 enrollments in our psychiatric urgent care, which we actually opened this in August, so it's only been a few months. We've had one readmission. We have 11 different agencies that we've referred people to for their agency of choice. And then the number of days to a follow-up appointment on average since we opened is 15 days for our external referrals and 12 days internally to get people in for that follow-up appointment. You can go ahead, Molly. So that's everything that I have. I know there are some questions in the chat, so I can answer questions, or if they're for Scott, I think he's still on too.
Great, thanks. There are a couple questions in the chat. The first one is, do you have very many clients who prefer to actually schedule a follow-up?
Yes, actually. All of the people that we see, we actually make scheduling the follow-up a requirement to be seen in psychiatric urgent care, because it is just a bridge to treatment. So we don't want people to use it as their ongoing provider. We work with them on what makes the most sense about where they schedule, and then we schedule them that way. As a best practice, we want to make sure that they are being set up for success.
Great. How long do you write your scripts? Do you limit the number of times you prescribe? If so, how do you address this issue?
Sure. So it depends on what's going on with the person that we're seeing in that moment. If someone has a follow-up appointment in 7 days, then we typically would write them 7 days worth of meds just to get them through to that appointment with the doctor. We are limited in number of days of prescriptions we can write by our own insurance company that insures us as an agency. So we can only provide within a year, we can only provide 90 days worth of medications. So we try not to overprescribe. If we know somebody has that follow-up appointment, we really only want to prescribe to that follow-up appointment. Because if they need to return and use the service again, we want to make sure that we can still work with them. We haven't been open long enough at this point to run into an issue where we have had to turn anybody away because we couldn't prescribe to them. And in the time that we've been open, we've only had that one readmission. So thus far, we've been pretty successful, I think, in linking people with those follow-up appointments, making sure that they can get to those so that that doesn't become an issue for us. We are piloting some crisis case management, trying to do a little bit more with that linkage and follow-up piece. So hopefully that will maintain some of those and keep those issues away from becoming a problem for us.
Thanks. I don't know if you'll know this yet, but what's your ongoing no-show rate like for clients who come from your BHUC?
Honestly, I don't know. I can get that information, but it's not something that I have on hand. It is something that we do track internally and with the external partners when we call for the follow-ups. And I know it's relatively low, but I don't have an exact number.
Well, thank you. Are there medications that people are seeking that you aren't able to prescribe?
Yes, so we do have some medications that we don't prescribe just as a best practice. There are certain instances where some things would be considered necessary for somebody, but it's not something that we would typically prescribe, such as if we saw a college student that was here that might have a prescription for Adderall that they can't get back home to fill. But typically we don't prescribe any controlled substances and we don't do any meds in hand. Everything is prescriptions.
Great. And then someone asked, did you say that you offer both psychiatric medications and MOUD?
Just psychiatric medications through the psychiatric urgent care.
Okay, thank you. We do have a few more minutes if anyone has any other questions, or I'd invite Courtney or Scott to, provide any other insight as we look to close out this panel.
Yeah, I wanted to just touch base on Courtney's last comment regarding medications for substance use disorders. I think it's important to recognize that Zeph Center has a detox and ambulatory detox services in which they can refer those folks into that unit as well, all on the same site. So it's not like they just ignore individuals with substance use disorders.
Yeah, thanks for that clarification. I think that's important to note that Zeph Center has that full continuum of care there. So if they can't be treated there, there's probably somewhere else in Zeph Center's system that can help them. All right, I think we don't have any questions right now. So I don't know if you had any last thoughts, Courtney, since you kind of are doing this, you're the boots on the ground person. If there's any last words of wisdom you'd like to share.
We've been very fortunate in this endeavor to be able to provide a lot of different services and to see how they all work together. It's been very just interesting and humbling to see how crisis works in the community and how it can provide real fill in a lot of areas that people struggle and get lost. And so psychiatric urgent care being a big one, but there's just so many other areas between the crisis stabilization unit and the mobile response. And like Scott mentioned, we have the inpatient substance use. So being able to kind of provide a lot of services to people, really give them that wraparound feel in sort of a crisis area when people are at their lowest. It has been very interesting, and I look forward to being able to see it expand and do a lot more in this community.
Yeah, that's awesome. It's awesome seeing you've been able to help so many people in, you know, a relatively short time, since this service has only been offered since August. So great job.
Thank you.
Yeah. All right. We only have a few more minutes left until we'll wrap up this webinar. I'll invite Molly to come back on and provide any last instructions for us as we get ready to dismiss everyone.
Yes, thank you, Elijah. And thank you again to all of you for joining us today, and to our speakers for another great academy. I'd also like to thank our sponsor, the Ohio Department of Mental Health and Addiction Services. The link to the two-part survey should be coming in the chat very shortly. You will also receive this in an email later today. Please complete these to help inform our future trainings and to receive your continuing education credits. And thank you, Scott and Courtney, as well for your session. Yep, so I see the link is now in the chat. So everybody have a good day.
Just a reminder, those who are still on, the survey link has been posted. It takes a few minutes to complete. We ask that you do it as soon as possible. CEU certificates will be sent out about 2 weeks after today. Molly, I don't see any other questions, so we can go ahead and close out this webinar, okay?
Okay, sounds good.
All right. Thank you everyone for
Bye,
attending.
everyone.